contributed to that error. It's not about the physician, it's about the process. Very difficult for us. The human beings in us want to go after whoever supposedly made the mistake, and usually it wasn't a human error, it's a systems error. But in terms of how do we get that, the leader has to talk about it, has to make a safe environment for that physician and the people who work together to talk about the mistakes. Really hard to do, very hard to do. But if you can get there, and there are some organizations in the U.S. who have done this. There's a couple in the U.S. Virginia Mason in Seattle, and there's one in the U.K. Salford Royal in the U.K. have leaders that are committed to this and have made the culture that they about CEO, CMO, CFO, the board. If they're not talking about these things, then you've got a long way to go on the quality and safety issue, because that's where that conversation has to take place very publicly so that everybody knows that that's what happened in the board meeting last month. We talked about that problem. Thank you.
Well, we have one last question.
Madam, good morning. Brigadier Sharma from Apollo Hospital, Bilaspur. It has been excellent listening to your presentation today. When you come up and cover over and state as to what are the responsibilities of the leader as regards the patient safety, at one point of time during your presentation, you said that the culture in the aviation industry is more negativity, whereas we in a healthcare sector have got more optimistic approach towards the patient. Things will go well.
I believe that that's a
now,
part of
when
this,
we
yes.
put that culture across, or we try to transform that culture from the aircraft industry, which is so very safe, switch it over or try to or partially take over whatever is the culture from aviation industry, won't we be creating a sea change in our healthcare employees, leading to a difference in the approach towards the patient?
The last part?
Leading
Yes.
to a difference
Yes.
in their approach towards the patient. Because if we buy anything from that negative culture or super safety culture or keeping the things safe in the aviation industry, the whole culture is, they are thinking something may go wrong. Whereas we always think that we can do much better.
Right. And that's,
So my point is, how much can we take on loan from the aircraft industry
I would argue,
to be safer?
I would argue we'd want to take as much as possible right now, because those industries are doing so much better at high reliability and error-free kinds of experiences. Karen Timmons' slide about the aircraft, traveling on an airplane versus going to a hospital. We have a lot to learn, and again, that's that hubris that we have. And it's one of our strengths. We are smart, we are competent. All of us are that, I'd like to think we all are, and we've gone into healthcare and we have a good contribution to make. But we need to be humble about the reality of the circumstances, that we're not doing the greatest job possible in terms of safety. So it maybe negative is the wrong word. It's a more realistic kind of outlook. To come to terms with the fact that we do make mistakes and we have a lot to learn. And not to be so overly optimistic that we know what's right and don't worry about it. That seems to be at the root of this problem to some extent. Thank you for that question. And thank you very much, everyone, for listening. I'm going to be around, so if you've got some other questions, feel free. Thank you.
Okay, as you kind of delve in your mind about whether to remain positive and exuberant, as well as learn from other industries which have a lot to teach us, we'll go through certain things that would be of interest to you. This is something which will be of definite interest to you, that please do visit the stalls and fill up the forms that are there and deposit your entries in the registration counter. And at the end of it all, there are goodies to be won, and you have to be physically present to win the goodies. And Shuja, do I disclose the goodies? He says, go ahead. There's an iPhone 5S because the 6S is not yet out, and there's a Samsung Galaxy 5. So there's a lot going. So please do visit the stalls, fill up the forms, deposit at the registration counter, and please also be physically present to actually collect the iPhone or the Samsung Galaxy S5. Okay. So go and do that. And yes, this is important. The delegate certificates will be available at the reception desk from 1 p.m. onwards. So if you need to collect it and leave, they will be available there. And along with it, this is important. Please collect the conference pen drive from the registration counters along with your certificates. And the pen drive contains this all right. Okay. So that's it. So the 5S, Galaxy S5, all for taking. So after you have had your tea and after listening to the free papers, please do that if you have not already done it as yet. Next we have something that we are looking forward to, and that is the free paper sessions. And to conduct the free paper sessions, may I please call on stage General Shiv Sharma, the Director of Medical Services from the Bangalore region of the Apollo Hospitals. General Sharma, please, and General Ella Sharma, the Director of Medical Services from the Indraprastha Apollo Hospitals, Delhi. So, General Shiv Sharma and General Ella Sharma, they will conduct the free paper sessions, and I'll leave it to them to do it. Thank you.
Namaskar. Good morning, ladies and gentlemen. A very warm greetings to all the distinguished guests, eminent faculty, and dear delegates. In this session, we have almost 7 speakers. They are icon in their own fields. And I am sure you all will enjoy the professional feast. We have Mr. Mani Shanguma from Department of Industrial and System Engineering, Mississippi State University. Mr. Mani is there? Dr. Himel Sangrula. Am I pronouncing correctly? Forgive me for if I don't. Dr. Manan Mirza. Dr. Gautam. Thank you. Mr. P.K. Bhattacharya, Dr. Anupama Shetty, and Ms. Chetal Naresh. Thank you very much. Well, the first speaker is going to talk about improving handoffs and transitions. Since yesterday, we are listening about how to make our patients safe. We are talking about culture, we are talking about human factors, we are talking about communication.
Milligram and 10 times the dose may be administered. One very famous incident of medication error occurred in Dana-Farber Cancer Institute in Boston, where a patient with metastatic breast cancer was prescribed cyclophosphamide, and because of the misinterpretation of the prescription order, very high dose of cyclophosphamide was administered, and she died because of the cardiotoxicity. Another area where errors can occur is dispensing errors. This can occur when two medications which look alike and which sound alike are the confusion is between the two medications which look alike and sound alike, and they are called SALA. And if you see here, the different strengths of the same medication, if they look alike and if they are particularly kept together, can lead to dispensing errors. Similar sounding drugs, there is errors between the similar sounding drugs. Keppra was prescribed and Kaletra was dispensed. Axate was prescribed, Antivert was dispensed. Now another area where medication error occurs is the administration error, and this is when there is a need to calculate the dose to determine the correct dose. And if you make a mistake in calculating the dose, you can make mistake in dosing and different dose may be administered. Now how can we improve medication safety, and how can we minimize medication errors? Now there are certain drugs which are associated with high risk of medication errors, and they are called high alert medications. And the use of these high alert medications must be kept to a minimum as far as possible, and the access to the medications should be limited. If you see here, this is the list of high alert medications. Insulin, morphine and potassium chloride top the list. So when you use these medications, care should be exercised to minimize the risk. Now, avoiding unnecessary prescription or use of the medication also can improve medication safety. If you see here, antibiotics are commonly prescribed for upper respiratory tract infections where the cause is caused by viruses, and the antibiotics are useless, and they only expose the patients unnecessary to harm. So no medication may be the best way of minimizing medication error at times, and if you use the drugs may not be good for another individual. So one classic example of the individualization of drug is primaquine. Primaquine, as we all know, this is an anti-malarial drug, and the use of this anti-malarial drug can cause hemolytic anemia in patients who have this expedient.
I'll request all the speakers to please stick to 7 minutes timing.
Yeah,
we are running short of time.
Individualization of drug therapy is very important, and everybody can make errors, but one who learns from the error and doesn't repeat mistakes is the one who is best. Thank you. Yes, thank you.
Thank you, Dr. Sama. That's very kind of you. I think all of us know that the adverse drug reactions can cause a lot of morbidity, mortality, and not only the mortality, it costs to the exchequer, there is a budgetary loss. Therefore, what is more important is to have these processes in place which the previous two speakers have just dwelled. Hello, can you hear me now? Yeah. I said all of us know that it's a adverse drug reaction do occur, and we try to prevent them, and these are the champions. They have given a perspective as to how to go about it. There could be many other methods of going around how to prevent many issues. Storage of drugs, high alert medications, look-alike medications. Then the doctors have to be legible, right dose to the right person at the right time and the right quantity. This has to be ensured by the staff. Therefore, in such a short time, he has tried to put across to sensitize people that adverse drug reactions are an issue, and we must be very, very careful while administering drugs. I think pharmacovigilance is the key factor, and in India we have a central organization, drug control organization, and a pharmacovigilance committee. But it is not going to fulfill its objective unless each one of us who prescribe medicine, who give medicine, including the nurses, the paramedics and the doctors, they must report any adverse event. In our country, this reporting is very, very poor. So therefore, I think all of us have got a role to play. If we want to have improved medication error, we must be pharmacovigilant and report any adverse event, and the staff must be encouraged that there won't be any punitive action. Even if you administered something wrong, please let it be brought forward so that our systems and processes can be strengthened so that such incidents don't occur in future.
Well, ladies and gentlemen, we'll have question answer session in the end of the talk, if time permits. I'll call upon next speaker, Dr. Gautam Wankede. He's from Jeevan Jyoti Blood Bank and Components, Nagpur. He would be speaking on innovative system to prevent sample and patient identification related errors of blood transfusion. Dr. Gautam, please.
Thanks a lot, sir, and good morning, everyone. Right, so I'll be talking about a very, very important topic, which is errors in blood transfusion. So just to understand the significance of this problem, I will first see if this works, number one. I'll move it forward. Okay, so the first thing I'd like all of you to do, obviously, is switch on your mobiles, because for us to understand what the gravity of the problem is, we need to understand. So obviously I won't ask you to do it, I'll do it for you now. Just enter the words wrong blood transfusion India, and let's see what comes up on Google. This is what comes up. This is not something which is, I've picked it, one by one. This is just the first page on the Google search engine. A large number of missed transfusions, a large number of patients losing their lives because a wrong unit of blood was given to them. So what do we do for this? The fact of the matter is we are making errors, and we need to find a way out of this. So talking about transfusion related errors, ever since the discovery of HIV over the last 20-30 years, there have been a lot of work which has been done to prevent infections. But transfusion process safety, the actual process of infusing blood or collecting blood sample, hasn't really received much importance. In fact, the human factor comes into play over here. We have automations for detecting HIV, HBsAg, HCV, but there's no automated technique to ensure that the right blood is going back to the right patient. So, in fact, even the Supreme Court of India says that the transfusion of wrong blood is an act of medical negligence. And studies have indicated that bedside errors contribute to 55 to 85% of transfusion errors, even in India. These are some of the studies that we've taken out from PGI Chandrika. That's the first one, which says that 82% of transfusion errors took place in the bedside. There was a study from SGPGI in Lucknow which says 55 to 85. And then there's one of the best hemovigilance program which is carried out in the UK, which is serious hazards of transfusion. And they've said that 60% of errors or near-miss events are because of errors of phlebotomy. So we need to find a system. In fact, this is just a paper which was presented 3 or 4 years back. So the chances of an error of a transfusion transmitted infection is 1 in a 1 million now, at least in the developed world. But the transfusion of no bedside check, the chances of a no bedside check, the chances of a mislabeled sample, wrong blood in tube is as high as 1 in 80 or 1 in 200, and that's how big the problem is. So we're looking for a solution. We're looking for a system which does not hamper the workflow. We're looking for a system that aids in the workflow and does not help in the does not deter the workflow of the nursing staff. A system that cannot be manipulated. A system that ensures a final and repeat check of the recipient before starting a transfusion. A system that is cost effective. A system that is easy to implement. And that's where I'm trying to talk about Hemovigil, a system that I've developed over the last couple of years with my work in the transfusion medicine industry. And we now have this system available in India. Basically, it consists of 3 things. It consists of a wristband which will be given to all the patients who are in a hospital who might be given a transfusion. We have developed a Hemovigil software which will be given to the blood bank. And there's a Hemovigil digital transporter, which is a temperature controlled digital box which in which we'll be sending back the blood. Quickly, we'll try to go through the process. So basically, the first thing is a wristband. Every wristband has a unique 6-digit number to it. It has 4 peel-off labels which are attached on the wristband, to the wristband. So whenever a patient comes to the hospital, the first thing that we do is we put a wristband on the patient. That's how. And it's quite possible that your hospital is already following a risk banding system, which is the case with most of the good hospitals now. So it doesn't matter. A patient might have 2 wristbands. One is specifically for transfusion, and that is as per the recommendation of PGI Chandigarh as well. The next thing we do is whenever we have to collect a unit of blood, not a unit of blood, a sample of blood, which is to be sent to the blood bank for a cross match. Now remember, a wrong blood sample going to the biochemistry is okay. At the most you'll get a lower or higher level of a particular chemical. But a wrong blood sample going to the blood bank will have fatal consequences. So it's very, very important that the sample collection, when you're sending a sample to the blood for a cross match, has to be absolutely perfect. So what you do at the time of sample collection, just the blood over there, they have to physically go back to the patient and they have to physically check the ID of the patient. If I zoom it, this is what the number which is present on the wristband of the patient. They have to enter this number and then only can they open the digital transporter box. So this ensures that the blood which was released from the blood bank is going back only to the same patient. If they enter some other ID, if it goes to B patient instead of A, they'll enter the wrong ID and the box would not open. So this in a nutshell is the system. This is the entire hemovigil cycle. So I just try to see what happens. We take a sample of blood, we peel off a label, the label sample goes to the blood bank generates an ID, the software, hemovigil software. We put that blood bag in the digital transporter, close it with the 6-digit number generated, and we can only open it after we have entered the same number which was present on the wristband. That's how simple the system is, and I've tried to stick to the 7-minute guideline. So I'm happy to take questions if there are any.
Thank you, Dr. Gautam.
I think let's give them big applause. We need such innovation. These are the champions.
Thank you. The cost of a wristband is just about $1, and you can do about 25-30 transfusions with that. So it's only about if you talk about rupees, not more than 5 to 7 rupee per transfusion. That's what the cost would be.
Thank you, Dr. Saab. Thank you so much.
Thanks a lot.
Since we don't have time for questions, they can all interact during our tea time.
I request the next speaker, Mr. Bhattacharya. He is the Director of Bangalore, India, Mumbai. He will be speaking on electrical safety for patients and medical personnel in healthcare facilities.
Thank you, sir. Good morning to everybody. Since yesterday, when I was in the audience listening to the eminent speakers, everybody was talking about safety concepts and variable parameters, but how to implement it? Because being an engineer, I thought to share with you regarding the electrical safety design in the hospitals, which is a very, very important aspect for patient safety as well. So, finally, the electrical hazards in the hospitals, fire is a very, very important incident or accident.
There was staff in one hospital. I have not presented the findings of another. Unit's response rate was around 38.8%. Not that great, but considering that I was an independent researcher in another institute, I think it was pretty good. And now, as I had mentioned, the safety climate survey, it primarily measures one domain, which is the safety climate domain or the safety climate score. I got a positive safety climate score of 56%. And just to put it in perspective, I've compared this study finding, which is in green, with the safety climate scores of other countries. Like, this is, I've compared it with the scores which have been taken from other ICUs, this is from other studies, and though we are a little lower, but what I would say is that this was just a baseline survey. Before conducting the survey, nobody had even heard of a patient of a safety climate survey, and I do feel that there is a lot of scope for improvement, provided that there is a top management support for having some such kind of surveys being done on a regular basis. And this, I would just like to share some of the findings. This was a safety climate scores which I compared across the units. You could see that the OT and also the casualty, they fared much better than the IPD as well as the casualty and the ICU. Now, what does this tell us? This tells us that the safety climate varies across units. Is this a normal finding? Yes. According to international studies, the variation which is seen, there is not much variation which is seen across hospitals, but there is a lot of variation which is seen within the hospitals. Dr. Pronovost had done a study. He had compared the safety climate scores across several hospitals, and this is one of his findings, that culture is context specific. And that is why I feel that this was, this finding was quite normal. And I also try to compare the safety climate mean across experience, in the sense across different groups based on their experience in the hospital. What you can see is that with experience or with greater experience, the safety climate has improved. The safety climate mean has improved. And just summing up the analysis, some of the non-punitive culture, they felt that there should be greater individual accountability for errors, and the system cannot take on the onus of error leadership. So this is just a snapshot. It helps us to assess what are your strengths, what are your weaknesses, what are your areas of improvement. And lastly, these are just some of the strategies. I've heard a lot of speakers discuss about some of these issues. The simplest one of these is executive walkarounds, wherein a senior executive or middle management executive, they decide to adopt the unit. There is greater frontline engagement with the staff. Communication tools, we heard about SBAR. Then there are team huddles. There is team steps, there's so many, for example, even a handover checklist, it just improves your communication. And then what I felt was patient safety science education, making the managers and consultants aware that individual accountability for errors is not the solution. Having the system you have to look at the system based, the system being responsible also, but at the same time, I guess there's a fine balance, And of course, then there's a multiple bundle of interventions wherein you kind of institute education, you look at engagement of the staff, and you put in some kind of newer communication tools in place. So these are some of the strategies. Of course, there are huge number of strategies. I've just put a few here on how we could improve the safety culture. Thank you.
Thank you, Dr. Anupama.
Thank you.
You all know safety in healthcare has received substantial attention worldwide since late 1990. Now what she has spoken about, we provide conducive environment to our people who work in hospital setup, train them, educate them, and once they are trained, educated, they will deliver the goods. Thank you, and we'll take the question answer at the end of this session. I'll call upon the next speaker is Ms. Chital Naresh. She is from Tata Memorial Hospital, Mumbai, the flagship hospital of our country which treats cancer patients. She'll be speaking on SWOT analysis of the sample collection area, a patient safety initiative at a tertiary care hospital.
Good morning, everybody. I think so most of us may be knowing what SWOT exactly means. SWOT means strength, weaknesses, opportunities and threats. So, we at our tertiary care center conducted a study using the SWOT analysis as a quality tool, and we started this with a small area. For this we chose the sample collection area to conduct the SWOT. The objectives of our study was to see the strengths of our sample collection area. If at all there are any weaknesses, then to take appropriate corrective actions. If there are opportunities, then enhance our services and be vigilant on the threats that may be imposed for the future of the services provided. The methodology used for this study was a comprehensive analysis of the sample collection area was done, and for which we used the inputs of our staff who are all well trained in quality management system. So the staff of the sample collection area were doing an observational study on prescribed criteria for strength, weaknesses, opportunities and threats. So also the study involved the evaluation of the TAT for the patients waiting for the sample collection, and this is the time from when the patients were issued the token numbers till the time the patient blood collection was processed. These are the criteria which we set out for describing our strengths, like credentials or qualification, the processes, systems, etc. I'm just skipping through these slides. Every organization can set in their own criteria. What we observed, the results what we observed was the TAT for the sample collection, that is the patient waiting, was observed as 30 minutes, which needed an improvement. And as we have seen that the credentials, the strengths that we have observed, we have divided into the credentials of the organization. As being a comprehensive cancer care center, it has already been well recognized nationally and internationally. The laboratories are all NABL accredited, hence most of the requirements of the sample collection area were appropriate. The staffing, we have well educated, qualified and trained staff who are subjected to frequent CMEs and updation of their knowledge. Also the staff are on rotation both in the lab and the sample collection area, which makes it easier for them to tackle the pre-analytical errors. The location of a sample collection area is in vicinity to the lab, which makes it easier to transport the samples from the sample to the collection area to the lab. Also the report dispatch and the collection happens in the same location, so it's easier for the end users to collect the reports at the same point. Equipments, we have a barcode system present which reduces the transcriptional errors. The evacuated system is used for collection, which is safe both for the patients and the staff, and also pronto holders are used for collection, which reduces the needle recapping errors. And patient benefits, of course patients are benefited because they are provided privacy during collection, and priorities have been set in for pediatrics, senior citizens and vulnerable patients. Separate areas are dedicated for the have been dedicated for patient waiting also, and the sample collection timings are also well displayed for patient information. And documentation, no expired materials were found in the area because all the stock is well reviewed and maintained, and there is a availability of a manual for private sample collection, which is for the reference of the staff. Health and safety of the staff is also well taken care of. All are vaccinated against hepatitis B, and also universal safety precautions are being followed stringently. Waste disposal, transport of samples are followed according to the regulatory requirements, and there is a complaint redressal system in place. The weaknesses that we saw was in the form of shortage of space. In the increasing workload, the patients and the relatives crowd in the same area, and it becomes difficult for the management to deploy an extra additional staff for phlebotomy. Also, the sample collection area entry is not wide enough to accommodate the wheelchairs or the stretchers. So this is one of the weaknesses. Also, FNAC is happening in the same area, and patient's waiting time is 30 minutes. And opportunities for improvement is again, if we are provided a larger space, it would be a good opportunity to improve, and we need to segregate the different areas in order to have a smooth flow of the system. The premises, early beginning of the sample collection would help in early dispatch of the reports, and also patients coming fasting would be relieved of their hunger pangs. And provision of a proper storage area, if made available because of the larger space, would resolve our problems. The threats that we observed is due to the longer waiting periods in the morning, patients, especially old and children, could suffer from hypoglycemia and may collapse. Samples for patients on stretchers and wheelchairs would become difficult for collection, and also there is no physical security to the sample collection area in times of crowding. So after conducting the SWOT analysis, when we got our strengths, weaknesses, opportunities and threats, We, in the 6 months period, we tried to take corrective actions in communication with the management, and we did succeed in doing most of them. And as you can say, we got a digital display or the calling system which increased the which reduced the TAT of the patient waiting. Also, we got a larger area for collection. The phlebotomy chairs enabled, extra phlebotomy chairs were provided which enabled faster collections. Barcode readers were also provided in the wards which reduced the time of transcriptional error, reduced the patient waiting time, and access control has now been provided for physical security of the area. So, to conclude with, the SWOT analysis of the sample collection area has given an insight to organize the, deal with the opportunities and the threats and the weaknesses and to eradicate them. And periodic analysis of the TAT for patients waiting in the sample collection area does help to reduce the TAT for the patients in the benefit of the patients. And just to share some, for a layman, it should be as good as this present is a strength, good in the future is an opportunity, bad in the present is weakness, and bad in the future is threat. And would just like to share some slides. This is the pre-SWOT analysis that you can see the wheelchair is difficult to bring in and there is all a congested area. Now the wheelchair can be easily pulled in, and this is the waiting area provided for the patients. There is a barcode reader now for sample accession. There is privacy during collections. More than 2 patients can be attended at a time. There is a patient calling system or a digital display outside the patient sample collection area, and all this SWOT analysis wouldn't have been possible without the help of the stakeholders, that is the staff of the sample collection area. Thank you.
Thank you, Shidul, for wonderful.
Thank you. Dr. Hybiz Sangraula. Thank you. Dr. Gautam Wankhere. Mr. P.K. Bhattacharya. Dr. Ella Sharma. Dr. Ella Sharma, may I request you to please give the awards to Dr. Anupam Shetty. Ms. Chitan Naresh. We now have a tea break. We have a 10 minutes tea break. Tea will be served in the food court. So we request you to please go ahead, enjoy your tea, and be back here sharp by 12 o'clock. Thank you.
check, check, check. Check, 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 check. Check, 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 check. Hello. Check, 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 check. Check, 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 check. Hello. Check, check. Check, 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 check. Hello. Check, check. Check, 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 check. Check, 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 check. Check, 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 check. Check, check. Check, 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 check. Hello, hello. Check, 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 check. Check, check, check.
Most accurately the question, what works here? I will not now call upon the speakers on stage. May I please have Professor Jean Marty on stage, please? Dr. David Grayson, Dr. Jacob Thomas, Mr. Anjan Bose, Mr. Tim Gailcock, Dr. Hans C. Osebar, and finally Dr. Nelly Nyam Opon. Over to you, Dr. Sibyl. May I please request you to kindly introduce the speakers. Thank you.
Good afternoon, friends. In India we have this saying which is Vasudeva Kutumbakam, which means that the world is one single family. Now if we look around, we are all united by technology today. I mean, look at Facebook. There are millions and millions of people connected. WhatsApp started in the United States and now everybody is on WhatsApp. When any innovation happens in any industry, the industry players in different countries quickly adopt whatever starts in one country. But when we look at healthcare, what might be happening in one hospital in one city is unknown to another hospital in the same city. What to say of this panel? And we are really happy that we are going to have a perspective which is truly global. So let me take the opportunity of introducing our esteemed panel. Professor Jean Marty, who is a professor of anesthesia and intensive care in Paris, and we had the privilege of listening to him. Dr. David Grayson, who is an ENT and head and neck surgeon, practices in New Zealand and has been the clinical lead for the 20,000 days campaign that CoAvita has run in New Zealand. And David was one of the key organizers for a fantastic conference that some of us attended, including Dr. Jacob Thomas last week in Melbourne. Thank you, David, for flying as long as you did, and we really appreciate your presence. Dato Dr. Jacob Thomas, a very respected figure in healthcare in Asia. Dato is the chairman of the Ramsay Sime Darby Health Network and is the president of the Malaysian Private Hospitals Association, has extensive experience in quality improvement, healthcare management and leadership. And thank you so much, Dato, for finding the time for us. And I know you were in Philippines last week and then Melbourne and then here, so we really appreciate the effort you've taken. Thank you so much. Mr. Tim Gallikop from Belgium. He's been working in the area of sterilization and infection prevention and has decades of experience in how we can make things more effective. Thank you so much, Tim. Dr. Hans Osbard from Get Up, Get Better in Netherlands. And I have to say that when I first heard about Get Up, Get Better and had the opportunity of listening to your team make a very passionate presentation in Paris, I said, well, this is just so exciting and we have to get you over, we have to get you to share your experience so that we are able to learn and perhaps an opportunity for us to partner with you. Thank you so much, Hans, for coming from Holland. And representing not just one country, but more than 50 countries from Africa, we have the president of the Kenya Medical Association, Dr. Eliniam Opat. Thank you so much, Dr. Opat, for coming and sharing your perspective. So what we're going to do is that we're going to have opening remarks from a very distinguished panel, and we'll leave it open for them to speak for about 10 minutes or so. And then we're going to throw it open because I'm sure there are going to be lots of exciting questions from our esteemed faculty from different parts of the world and India, and then we try to make this as interactive as we can. So may I take this opportunity to start with Hans, if I may request you to come up and say a few words. Yeah, we'll go first.
Okay. Okay. Good afternoon, everybody. My name is Hans Ossebaard. I'm affiliated with the Dutch Healthcare Quality Institute, where I specialize in e-health. But today I want to introduce you to Get Up, Get Better. which is, for me, a very unconventional project that strives to organize an international competition for the improvement of safety and quality in healthcare. Actually, it is a citizens' initiative. Two people came to our institute and said, well, we believe in the inherent motivation of healthcare professionals, and there's so much critic on them, on the nurses, on the doctors, on what goes wrong, but how could we kind of reward them and put them in the sunlight and strengthen their position? How can we boost patient safety and quality of care in a playful way, not just with indicators and measurements and science and seriousness, but also in a inspiring way? And they came up with the idea of a cooperative competition, like the old days Olympic competition, where the heroes were teachers. You could learn from the heroes, and maybe you could even learn more from the followers. Okay, I show you, just to show you the idea, I show you a little movie. It takes about 2 or 3 minutes.
In the imposing arena of healthcare, thousands of people set personal goals and passionately strive to achieve them. They're not in it for the money or medals. So what is their motive? Their motive is a simple one. They're driven by the profound belief that curing the sick is their mission. They try to excel in the role they play in improving the lives of other human beings. That's why they do it. You're one of those people. We want you to share your skills, your expertise, and your aspirations. We invite you to compete in order to excel even more. If patients, public and professionals join forces, we're able to build on each other's knowledge and experience. If we set collective goals, nationwide, worldwide, we make it possible to reach them. And when we reach them, the quality of human life will improve. Wasn't that the purpose? Get up.
Okay, later on I will invite you to join this international healthcare competition. But first, why would a healthcare quality institute support such an initiative? Well, in fact, we have a few statutory legal tasks in the Netherlands. We have to promote quality standards and to take care that stakeholders in care develop these standards for good and safe patient care. But we also have the task to stimulate the implementation of healthcare standards, the legal task to do so. But how do you do that? Implementation really is the buzzword in the Netherlands. We already have so much knowledge, but how do we get it to the ground? Implementation. So this is for us the Get Up, Get Better project, one way to, in a playful way, stimulate implementation of health standards. Of course we use science, we use improvement sciences, we use health services research and implementation sciences, which is a relatively new branch. But the question remains, how do you motivate professionals? From research, we know that financial incentives do not really motivate in the long term people. There's something else is needed. A recent study in the British Medical Journal also conclude that financial incentives are not the magic bullet, and we thought, what would be the magic bullet? Would that be cooperative competition? Because we know also in India, in the branch of cricket, and also in the Netherlands in terms of football or skating, that competition can be very much inspiring and creating a brother and sisterhood internationally across borders. Well, who should be rewarded? Should it be the leader or the lone nut who is inventing something? This is a little movie I'm not going to show you, but I really love it. It's about a boy who starts dancing, maybe you know it, on a slope of a mountain, and a few people join him. And the lesson to be learned from this simple human, sweet interaction is that you can only be a leader if you have a few followers. If you don't have the first 3 or 4 followers, a leader cannot exist. And this is actually what we want to do in this international healthcare competition. We want to reward the followers. That could be really anything. The values that we cherish in this competition, the perspectives, are knowledge, participation, communication, human dignity, and also the skills that are necessary for implementing improvements in healthcare. These are the themes that the contributions will be judged according to. Well, we do not really know what the areas for competition will be. There should be a kind of international comparability, which is of course very hard. There are not many healthcare indicators which allow for international comparisons. But this could be hygiene at the ICU. It could be stroke. It could be media projects. It could also be a project that lowers the rate of decubitus on a ward. It could really be anything. It could be a mix of public health, cure, care, or prevention, both sent in by professionals, by the public, but it should be more or less comparable. Yeah, comparability, I didn't do that. Comparability is really a big issue in science. We would really like to compare hospitals, we would like to compare between countries. And yeah, always the question is what should have the highest value, process indicators or outcome indicators? And if you take the time to read this, it's actually quite interesting, is that, well, actually outcome indicators from a patient perspective are much, much more important. In this specific research, patients who choose their hospital based on higher rates of process compliance, they do not really improve their chance of reducing complications. The same goes for this. It's very interesting. Actually, patients prefer to be treated in a human way much more than clinical outcome. Very interesting. Patient-centered care. So they measure outcomes that really, matter to patients. That is what we strive for. We are helped with this by ICHOM, the International Consortium for Health Outcome Measurements, and they have developed a few indicators that allow for comparison. But I won't stay too long on this. How we organize this competition? Well, we have a website. On your table, on the tables here and at the back, you will find a little leaflet with the URL of the website. And we will, this month or in October, we will put out the challenge and we will organize a community that supports this international healthcare competition. Finally, the judgment will be made by specific experts, for instance, in ulcer treatment or in infection control, together with the judgment of the community. So we will use social media in this enterprise. What we do, we try to organize it in a kind of how the Olympic Games are organized. We try to organize a national hub, for instance, in the Netherlands, and we have hubs now in Italy and Scotland. And actually, I hope to challenge you to come to me afterwards and say, hey, I would know something more about this idea. And maybe I would like to be an ambassador in my country, and I would probably challenge Apollo Hospital to be one of the ambassadors for India. But we have so many countries here, it should be possible to make Get Better success. And what actually would be the outcome? Well, our values are actually very clear. Curiosity, cooperation, and clarity. What we do is not rewarding in financial terms, but we will reward the winner in terms of attention and well, global attention. Every year we present this at the IHI Patient Safety Congress. The next is being held in London, and we will hopefully present the first winners. There are only 4 rules. Patient benefit should be at the center of the competition. The achievement should be more or less comparable. At least 3 contenders, 3 competitors have to take part. And, well, the competitor has to propose it yourself. If you work on a ward as a nurse or a doctor and you think, well, this is really a safety or quality improvement we have last year, this is something other people could learn of. This is something, you know, I'm not afraid to show to the world. Okay. At the moment, the National Hub is established in the Netherlands. And this is how we hope to do it, together with patient groups, of course, together with professionals. We will raise a community, and we hope to find, of course, some sponsors. The first sponsors have already been noticed. Well, the key question, of course, is, yeah, what area, what improvement is actually made? What is lending itself for competition? This is for us still an open question, but we have a lot of specialists and competitors who take care in this. Okay, we will judge these contributions according to our values of communication and human dignity and skills and participation, and it could be really anything. It could also be a media project. As long as it appeals to an international public, we will facilitate this competition with our expertise and resources. So there will at the end be a jury panel nominated by the Get Up, Get Better community, which will decide on the winner. Okay, and this is a slowly growing competition. We have just started this year. We presented it in Paris at the IHI Patient Safety Conference. We presented here to you, to Asia, and we really yes, we would invite you in Asia to join this competition and start up the challenge to, well, to show what your big organization, what your small ward, what your community has contributed to quality improvement. So, yeah, I invite you to have a look at the flyers. Maybe check with me afterwards and join us in this competition, which is a playful way, an extraordinary way, also a learning experience for improving patient safety and patient and quality of care in health. Thank you. Thank you very much.
Thank you very much, Hans. I'm sure that post your presentation there'll be a lot of interest from Asia, and I'm sure that you will have quite a few people writing in and wanting to become partners with you. Let me now invite David Grayson from New Zealand. I must tell you a little bit about the institution that David and Jonathan have created in New Zealand. Their organization is called Co-Avita, and they are 1 out of 20 counties in New Zealand. They have a population of 700,000 lives that they cover. They have a budget of $1.4 billion to do that, and what they've done is look beyond New Zealand and have created the APAC Forum. And the idea of the APAC Forum is really to exchange best practices across Asia and the Pacific. And of course, David has been leading this 20,000 Lives campaign, and may I now invite David to share his thoughts.
Namaste. Thank you, Anupal. Kia ora toto. Hans, your talk is just perfect for what I'm going to be talking about, because we've happened along a similar approach to the problem of dealing with large numbers of how you actually get a lot of involvement, and I'll definitely be talking to you after. So as Anupam said, I come from an institution, it's actually a hospital, but within the hospital we developed this quality improvement and patient safety innovation centre called Koawatia. And Koawatia in our native Maori language means the dawn of the first light, and it signals that potential and opportunity that is at the start of every day just as the dawn comes. And I thought the talks yesterday around the meaning of light and the lighting, the ceremony of lighting of the ceremony yesterday was so pertinent for us, because it's how we share knowledge and get action. And so we've been particularly interested in New Zealand of how we can actually get involvement right down to every level of the hospital and including in our community. And we've taken an approach of running collaboratives, which our unit has been leading across New Zealand in a national collaborative to reduce central line infections, and in a regional collaborative that we've just started around patient safety issues in primary care. And also, as Anupam mentioned about the 20,000 Days campaign, and that was a specific one for our community. And so I'll just talk to you a little bit about those now. And there's a nice picture from space of the upper part of the South Island in New Zealand. Anybody ever like to come and visit, you're more than welcome. So our hospital that we're based in is Middlemore Hospital, which is a tertiary teaching hospital, about 900 beds. And we have probably the poorest community that we serve in New Zealand, and lots of difficult problems, particularly with so many different nationalities represented there. We have about, I think it's between 90 and 100 different languages that we deal with. And the Koawatia Centre was set up as a partnership with our hospital, but the 3 local universities that train all of the various healthcare workers in our region. And I think the interesting thing, I mean, obviously competition is good, but you can still have competition in a collaborative way, even though that may sound strange. And before coming here, this is my first visit to India, and I've just loved it. Thanks, Anupam, for the opportunity. I did a bit of research before I came, and I read this fabulous book, which I'd encourage you to read. It's called India, a Portrait by Patrick French. And in that book, he refers to the beginning of the modern nation of India and how you overcame such a vast number of different nationality type, particularly religions as well, and managed to get over all of the differences that you had to actually come together and build probably the world's the best democracy. So I think you guys are natural at this. Obviously we all are natural when we're little. Kids just naturally do this collaboration bit, but somehow we seem to lose a bit of that along the way. So in terms of when we're doing these collaboratives, they're actually formal projects, if you like, and we follow the model for improvement. The model for achieving breakthrough improvement that was designed through the Institute for Healthcare Improvement. And so it's quite a structured process that we follow. We bring together teams, we choose a topic that's of importance, and then we invite all the teams to come together, and then we set up a series of what we call learning sessions, which is the LS in the box there. And in those learning sessions, people learn how to approach a problem and how to actually approach it in a methodical way, work out your measures that you're going to do, and then do a whole lot of runs of tests of what we call the PDSA cycle. And you follow through, and it's usually over 12 months or an 18-month period. And it's kind of nice just having a very short, focused effort to get on and do the work. So this is the model for improvement that we follow. And it's a nice, simple, very structured way that we can just get action and get people working, and it overcomes all of the interdisciplinary problems you may or may not have wherever you work. So the first one I'll just talk about was across the country. So this is a map of New Zealand outlining all the different regions. So each one of those regions will have several hospitals within it and varying population. New Zealand in total is only about 4.5 million. But the population is very spread out, which does give some challenges in terms of getting across to various groups. But we knew for a long time that we have the problems like everybody else would have in terms of central line infections in a hospital setting. And so we followed the collaborative that Peter Pronovost had done in the States, in the Michigan state, and followed that through. And by bringing the teams across the country together, we're able to get dramatic results in a fairly short time frame. And it was really mainly because people were quite motivated to actually do something. A lot of them didn't even know what their central line infection rate was, so the first thing for them was to actually start measuring it. And once they all measured, and then they were able to compare the results across the country, not only comparing just in a local, regional sense, then that really instilled a lot more collaboration in terms of how they approached it. And so in terms of the detail, they reduced the rate of central line infections from 3.3 per 1,000 central lines days to 0.28, and they managed to maintain that through, and it's carried on. So that was, the collaborative was just run over an 18-month period, but now it's pretty much been bedded in, and the results are now being monitored, but being monitored back on each hospital state. But the key part of it was that they developed this national database for doing so, which really helped them. And so in terms of, from a safety aspect, certainly saved quite a few infections, but along with that prevented a lot of lives to being lost. And the estimate from us was at least 10 to 15 lives in that time. But another unplanned sort of benefit of it was that it just immediately caught on in each hospital, and other units that were inserting central lines wanted to know what we were doing and to take it up. So it was really successful, and I really would encourage you to think about that as a really good approach to try and get buy-in from everybody involved in any particular unit. And it made me think, I tried to look at just what would be the situation here, sort of, magnify it up a few million times. I got some data that was available from an infection control meeting you had here last year. So you can see from this just the scale that you're dealing with, but likewise, if you can improve it even in a little way, the amazing amount of savings that you would potentially make, and the incredible improvement you'd have in terms of from a patient's perspective. So the next example that we had was one that we've just started, and that's dealing in primary care. In the New Zealand system, we have hospitals, and then we have primary care practices run by GPs. And GPs in our system are privately owned businesses, and quite often for us, the hospitals are a publicly owned setup, and it's quite hard for us sometimes to engage with privately owned GPs to actually come together and spend time doing work. But this was a nice outcome of the APAC forum that we run once a year, and we had a visit from Neil Houston, who was a GP who led the patient safety program in primary care in Scotland. And he spoke at this forum that we had, and so this picture here is Campbell Brebner, who's our director of primary care in our hospital. And so we decided we'd like to just emulate that collaborative program here in New Zealand. And Neil is now like our advisor, and he joins us. He's come out a couple of times a year and in the setup for this, and he also joins us over video when we're having our learning sessions. And so it's not only a collaboration in our local region, it's an international collaboration. And I think that's the wonderful thing about these meetings, is that you start to make these connections, and it just takes a few willing people to set these things up, and away you go. So they're looking at 3 different areas: medication reconciliation, how they handle results. We're lucky in New Zealand, all our primary care practices do have electronic records, and but it's still a big problem for them in terms of when they're getting results, particularly coming from the hospital, as to how they handle that. And then the third one is warfarin. And so this is matching exactly what they did in Scotland, so it's kind of nice that we can make the comparison with how we go as to how they've made progress in their neck of the woods. And also, this is an optional thing that they're doing it, but the practices have just volunteered to take this up. They're using the global trigger tool, and they're doing a safety culture survey in each of their practices. And it just shows the enthusiasm that they, once they get this and get going with it, it's just fantastic. So the final collaborative I want to talk about is our local one, which I helped to run and to organise. And we were faced with a problem in our hospital that we were dealing with increasing growth in the terms of demand for hospital beds. And we just knew we couldn't keep on building more beds, mainly because we ran out of money. And the reason for that was there was a massive earthquake in Christchurch down in the South Island. And so all of the government spending on healthcare and building new buildings was prioritised down to Christchurch. And all the rest of us said, sorry, we're told there was just no more money to develop or build any further buildings. So we set about working with our community to actually run, it's sort of like a collaborative within collaboratives, because we had 13, 15 teams that were all looking at different aspects, from community, primary care to emergency department to within the hospital, all looking at how they might try and improve their little piece of the puzzle and help us to actually save what's the number of bed days that we count each year. And we knew from projecting figures that we were going to need at least 20,000 extra bed days over the 18-month period that this collaborative ran. And so we set about doing that. And the example here is just one of the teams that worked inside the hospital. It was a pharmacy team who worked with the medical doctors, the physicians, and they worked on trying to improve the accuracy of medications that were prescribed for patients when they came into hospital and then going back out. And they had a really nice connection with the community pharmacists, making sure that patients were taking the medications they were supposed to and that there weren't any glitches. And they were able to save on the medication areas in total for when the grading of the grade 3 and 4, 5, which are the main areas that can occur. And they calculated that they would actually have saved around 402 bed days in the course of their work, which was just fantastic. So kind of cool that we got the same picture. But I, again, just want to stress, I think you guys in India are perfectly positioned. You're passionate. You really get how to work together, not only in the sporting field, but obviously in healthcare. And so I'd really, like Hans before, would challenge you that you're perfectly set to do some collaborative work to actually take your next sort of quantum level step in promoting patient safety and improvement. So my final pledge I saw in the Hindustani Times today in the editorial promotion for Congress to be increasing their social media use to contact with the population. I'm really interested because I've been busily tweeting away from this meeting and I haven't really seen too many other tweets coming out of here. There's a few coming out of the health IT one, but we've found that using Twitter in our case and running these collaboratives has been really helpful because it's a great way to keep the conversation going after you're in any given meeting, and likewise make fabulous connections, even though they may be only virtual connections. So I'd really encourage you, and like I said before, please welcome anytime you want to come to New Zealand, then just let me know. I'd be more than happy to help out. So thanks again, Anupam.
Thank you very much, David, and we look forward to building a collaboration with the APAC Forum, and I'm sure next year we'll have some exciting news to share. And thank you very much for showing Hans and David the hopes of India winning the World Cup, and I'm sure Cliff is not going to be happy because I know you don't want Australia to win either, so I guess the Kiwis and India can play the final in Melbourne in the next World Cup. Now moving on from Europe to New Zealand to Asia, may I now call upon Dr. Dato Jacob Thomas to share his perspective from Malaysia and Asia.
Thank you, Professor Sibal. Namaste and good afternoon to each one of you. I want to thank the Apollo family for this kind invitation for me to come here to Calcutta and to share some things which I think we've been talking about patient safety the whole of yesterday and part of today, and this might be a repetition because the issues which you face in India are very much what we face, so there might be some repetition. I'm coming back to Calcutta after 40 years. I came here 40 years ago to meet my father-in-law, who was the general manager of Calcutta Telephones. And so it brings back fond memories of meeting my wife here and also going along Park Street, Fleury's, Newmarket. Some of those places are here not present anymore. So I'll just take you quickly through a few things. First of all, greetings from the Association of Private Hospitals and congratulations on such a huge conference, and I think you have set the pace not only for us in Asia but for the world, because I'm yet to attend another huge conference and support from the management, which I see so clearly from Ms. Preeta Reddy and Sangeeta and the rest of the team for this movement for patient safety, and that itself speaks volumes of what the Apollo Group tries to achieve. This is the hospital where I work with, part of the Ramsay Group. It's quite a new hospital, about 2 years old, and it's and that's where my office is. It's in Kuala Lumpur. Now, we've heard about this again. I'll repeat it. Medicine used to be simple, ineffective, and relatively safe. Now it's complex, effective, and dangerous. Now, how unsafe? We've heard this repeatedly. Healthcare is right on top there, and one of the safer areas is air transport. We've heard this again and again, and let me say, we've heard about air transport and pilots being trained to be as safe as possible. In our environment, there are 2 hospitals who have engaged pilots to be the head of department for the patient safety department. And they compromise with nothing but zero error. So they try all means to get to that target. So why do we make so much of a fuss for improving quality and patient safety? Is 99.9% okay? Just 0.1% short. If that is okay, 4,000 families per year would leave the hospital with the wrong baby. 70,000 patients per year would experience the wrong side procedure, patient surgery, and it goes on. Now, so why are we prone to so much of errors? Because of the variable input, complex procedures, non-standardized, tightly coupled, heavily dependent on human intervention, and we talk about team versus hierarchical, time constraints and loose time constraints. So we've again heard about to err is human beings. To err is human, and human beings by nature make mistakes. Therefore, it's unreasonable to expect error-free human performance. And we also heard that 60 to 80% of accidents in aviation and other complex systems are caused by human error. Now, how do errors appear? We talk about sentinel events, but we should not focus just on those events, but just remember at the bottom of the pyramid, there are huge amounts of near misses. And that's why it's so important for us to document and act on those near misses so that we are able to address and reduce the number of sentinel events. So what is a culture of safety? It is an integrated pattern of individual and organizational behavior based upon shared beliefs and values that continually seeks to minimize patient harm related to high-risk processes for delivering care. Now, people are often afraid to talk to their leaders about problems they encounter, and this fear keeps dysfunctional processes still in place. But everyone has the power to impact patient safety if healthcare executives can build trust in their staff and encourage them to offer clinical feedback where it's needed. The hospital will become a much safer place. And this was said by an Air Force veteran. So we have to move from a culture of silence to a culture of safety. We have to speak up. We heard a lot of this, especially from the nurses. So we also talk about patient culture must address that healthcare has failed to produce significant patient safety improvement because we have failed to change the culture. Failures in perception, failures in assumption, and again, we have been talking extensively about communication. Now, how to create a culture of safety? There are some organizational functions, leadership engagement. We heard a whole lecture this morning from Paula Wilson about the leadership engagement, a culture of learning, and talking about accreditation and robust performance improvement. This shouldn't be the case. It is leadership behaviors that increase risk and make healthcare less safe. And to err is to be fired in some, or used to be, and fortunately this is changing. I'll skip some of the slides. Way of thinking before was who did it, but what we are talking about today is what allowed it. From punishment to thank you, from errors are rare to errors are everywhere, to recognize that MDs or doctors don't participate, but everyone should be involved, and more complexity which should be simplified and standardized, and error rates should be calculated. Now, doctors are well prepared in the science of medicine, but we know that few are qualified or trained with skills to improve care and improve patient safety. At this juncture, I want to say something. We have a cardiothoracic surgeon in our hospital. We talk about training of doctors. Now, this cardiothoracic surgeon is a stickler for patient safety. He doesn't compromise at all, and is at slightest excuse cancels the surgery. You know why? He was taught properly. He had his education for cardiothoracic surgery in Sydney. And do you know who his professor of surgery was? None other than Professor Cliff Hughes. And if you have teachers like him who educate them right from the beginning, not just for nurses but also for doctors, you'll find that things can get better. So there are various things which we need to learn, and we need to get those skills going. But I think our service philosophy should be to delight our customers. And this picture tells it all. Patients who come to us should say, wow, I didn't expect this hospital to be so safe. So the 4 C's of change, we also see collaborate there, and that means in healthcare to benchmark. So benchmarking can be in various ways. It can be within a hospital. Why is Professor Anupam Sibal's department safer than another department? You can compare and improve. You can also learn from hospitals like what we are doing today, sharing information about each other and moving forward. So the role of leadership, I cannot emphasize this more. We've heard lots about it, and it must be the core of every organization. And it should be a non-blaming culture, and we can go on. And we also have to look for a reason to change. This has to be pushed. And the cost implications, we are talking about the Director of Finance to be also involved. Board level involvement, I want to say a few words about this. Today I'm the chairman of the board. When I was not there, risk management used to be right at the bottom. Today, I insist that that has to be discussed even before we talk about finances. So it is heard, the management knows is important, and we move. Now, the role of governments, we've not emphasized enough. Fortunately for us in Malaysia, we have a patient safety council, which is chaired by the Director General of Health himself. He is an endocrine surgeon. Aims to ensure a safe environment, involves the Ministry of Health, universities, private hospitals, the societies for quality in health, the private hospitals, academia, the whole lot is involved, and he chairs it, and we meet at least twice a year and sometimes more often. So the aim of it is the government pushes patient safety now, and because of that it's easy for management to ensure that there are people doing it. And we follow the international patient safety goals, which is set up by WHO. Now, I will skip some of this, but I just want to also say that there was a saying by Paul O'Neill on safety that can each person in the workforce answer these 3 questions every day? I'm treated with respect by everyone, regardless of what position, education or pay. I have the support to develop my full potential, and my work is noticed and appreciated. So to summarize, keep things simple and clear. Consider data your best friend. Collect data, and that will tell you the truth. presume change and manage it, practice the processes, set staff expectations. JCI helps. They have a lot of areas in which I think we have heard this, and working together with WHO, and come and visit us and learn from us some of the things. And I'm learning so much these last 2 days, and I'll continue to do that with your excellent team here. And thank you.
Thank you, Dato. And you really have a very nice office. Next time any of us is coming, I'm sure we'd like to pop in and have coffee with you in your new office. You know, Dato said something very, very important 4 days ago in Melbourne. And I think that's very relevant for us in healthcare. You know, there have been 2 unfortunate incidents with his airline, Malaysian airline. And when the second incident happened, Dato was in the United States and he was flying back to Kuala Lumpur, and his family called and said, "Are you sure you want to fly Malaysian? Shall we change the airline?" And he said, "Absolutely not. I have full faith in the safety that the Malaysian Airlines believes in. It's an incident that happened which was unfortunate. It has nothing to do with safety." And I think what we need to be able to learn from that is that each one of us in healthcare needs to have such robust systems that when something goes wrong somewhere, people believe that our systems are strong enough for us to be able to look at what went wrong and to make sure that that never happens again. So from Malaysia back to Europe, and may I now call upon Tim from Belgium. Tim, of course, other than the fact that he's been 35 years in healthcare, is a very multifaceted personality. I just discovered that he's a script writer. He's also directed a film and has acted in a film which has been translated into 13 languages on how to improve sterilization in hospitals. Tim.
Ladies and gentlemen, good morning. First I have to apologize myself. I'm not from Belgium. I'm really Dutch, but I'm living in Belgium. Now, does that change a lot? No, it doesn't. First of all, I'd like to thank the organization of this very, very important Congress, and especially towards the Apollo Group, who put all the efforts into it. I think as experts in your representative fields, you are all aware of the global problems concerning infections and viruses. So infection prevention has been, yes, I've been for decades in, and I find myself now a dinosaur, 36 years. I have been in this field. And that's where I will focus on for the next 12 minutes. Since 1980, I'm dealing in the Netherlands with the standards and laws for the Dutch hospitals and industry. So there is quite some things going on, and that's where I'm very pleased with the things which Ossenbaard is doing. And guess what? The world is so small that this gentleman is working in the town I've grown up in. That was a long time ago, by the way. During these 2 days, you had such an amount of data, and enough data, statistics, graphs, tables, and surveys that I'm not going to use this time. I see you thinking, there's another one of their foreigners telling us how to do it and what we have to do and we do it better. I'm not here to tell you that you do things wrong. I'm here that you open your eyes and might maybe see the perspective in a different way. So my first question to you all is, what is the difference between a patient in Kolkata and Amsterdam? Well, maybe you can tell me afterwards. This is what you have seen every single day, newspapers. And by the way, this is the first time I'm reading my text from a piece of paper to try to keep within the 10 to 12 minutes. gone again, so I will start. Yes, I have to agree what Dr. Sibal said yesterday, that healthcare has changed a lot. But according to me personally, I don't think always in its favor. And these are the publications, the newspaper you see nearly every day. And this is where patients are getting afraid. That is maybe strange that I say that, but that's what you hear in the field. And the film which was just referred to is a film which we have made from an association to show the great public what it is all about, sterilization, and how scientific sterilization is. And you will find it back as well on YouTube. So have we come into a doom scenario? That's a very good question. And I'm not going to go through all these kind of things, but we have a severe problem here. And I think at this moment of time, every single day, I can change my slide over there and add a new virus or a new mutated virus, which is scaring me the hell out of it. Not to forget that bacteria and viruses have never been faster ever before than today. They travel fast by plane. Oh, well. Okay, let me talk to you a little bit about the sterilization department. I have experts in this room, and I want to see some hands. Who has ever visited a sterilization department in his hospital? That is 10% of all the experts around this room. So I think if you want to know what those guys are doing for you, and that's why I call it is the heart of the hospital. If the heart of the hospital does not pump, you cannot operate, you cannot work, you can't do anything. And again, I think it is of an extreme importance that these people are getting more respect from the hospital management, but as well from the surgeons, as everybody who's using a sterile medical device. Those people are not stupid packers. They are not the dishwashers of the operating room or theater, as you say it here. They are experienced, they have a huge know-how, and they take lots and lots of responsibilities about sterility every single day. They have to take decisions which are extremely important. Cleaning and disinfecting is today the most important thing of a sterilization department, not the sterilization. Sterilization is done by a machine, but the cleaning and disinfecting is the most important thing, nothing else for me. So make your bioburden as low as possible on your instruments. And then I think every single day, and that's why I was so pleased that somebody told something about turnaround time. Those surgeons coming into the sterilization department or the nurse stating, I need my medical device sterile in 15 minutes or 20 minutes. It's impossible, and therefore you need to understand them much more. We are using in the Netherlands a system because sterility has nothing to do with time. Expiration of sterility is event related. And therefore we have developed a kind of point system so you can calculate your own expiration date, which as well will reduce cost. Now one thing I'm going to say as well is that every time wherever I get into the world, they tell me that a sterilization department is the expensive part of the hospital. Nothing is more true than the opposite. It is saving money for the hospital because you get your sterile products and we can reduce infections. So I'm not going to run through all these because I don't have the time. And this is the first time I have to explain something in 12 minutes. But if I take that we talk all the time about patient safety, what about staff safety? The amount of times I ask people in the operating theater, do you think you are safely dressed? The answer in 90% of the cases is no. If I go and take that I heard that we don't have standards in India, I have to disappoint you. There is an international standard for packaging systems, sterile barrier systems, but work with it. It's not written for nothing. Harmonized standards are in the future the most important thing for the whole of the world. And we need one standard. We don't need a European standard, an American standard, a Japanese standard, and a new standard in India, because it's unworkable for the industry, and on top of that, it is creating mistakes. The Netherlands, by the way, was the first country in the world with a medical device directive, the law, and that was due to a big problem where 12 people died in a hospital. One thing I'm going to say as well is that Dr. Mayumbar mentioned yesterday, patient safety leads to satisfaction. I think there's another one. However, also mouth to mouth, patient to patient, in the towns and everywhere is an excellent advertising. I came out of a hospital not in a wheelchair but walking. That's rude, I know, but that is the reality. Hospital procurement, in the morning taking care of the dinner ingredients and dosas, and in the afternoon we're talking about medical devices. Personally, I believe you cannot know everything about everything. You are not able to know everything about a potato and at the same time decide on a medical device. It's impossible. That's why the industry is using different people. So let me go forwards because, oh my text, I've got it, it's blowing here. So what is the way forward? I mean, it's impossible to go through all those points in that way, but one thing I'm going to call is stop reusing single-use products. They are not designed for it. They are maybe re-sterilizable, but you cannot clean them and disinfect them. It's a disaster, and I'm sorry to tell you, we get a new directive in Europe, and one of the things which is written in there is re-sterilize single-use. I think those Europeans have gone out of their minds, and they don't know what to say anymore. So that's what they do in Brussels, by the way, and that's where I'm living. So let's go to bed. I hope this is not what you think it is. What is the way to bed forward? BED, back to basics. And maybe we should not go back to the times of Joseph Lister and Florence Nightingale. But don't forget what they have done in aseptic techniques, cleaning, hash washing, and cleaning departments. But we certainly have to go back to hand washing. And yes, I'm pleased what happened globally, what the World Health Organization did. But there are so many other things. I'm giving two examples. The way of opening sterile barrier systems. And the other one is, how do we use a face mask in hospitals? Think about it, because the face mask is the most dirtiest thing which you can imagine. And we walk with them through the whole bloody hospital, I'm sorry to say. Paula has said it very, very well in her slides as well. I think education went as a red line through all the presentations. So why don't we do it? It is not only the hospitals who need education, it is as well the industry. I find it shocking to know and to see the answers from the industry about their own products. They don't have a clue what they have to say about the products. Professor Apam Gua said it in the way which I cannot improve. Poor training and education. Actually, the lack of education ran as a red line through all the presentation. And discipline was mentioned this morning and yesterday by Mrs. Usha Banare. Please let us all wake up. Wake up! Sorry, I'm screaming, but that's for those who fell asleep. But let us change our attitude as well. So, a chain is as strong as the weakest link. Manufacturers can make the best medical devices, but what will happen if they are used wrongly? Providing quality costs money. Failure in providing quality costs even more money. So sorry that I didn't have a picture of a football team player or whatsoever, but I want to thank you very much for your attention, and keep in mind, infection prevention is the best attack.
Thank you very much, Tim, for a fascinating presentation. And now let's shift the spotlight onto Africa. And from Africa, representing Kenya and the continent, is Dr. Opert, who's the president of the Kenya Medical Association and a consultant surgeon at the Kenyatta Hospital in Nairobi.
Good afternoon, everybody. It's a pleasure to be here, and I want to thank the Apollo Group for inviting me and for making sure that I'm here. I want to shift focus a bit and just highlight some of the things that perhaps have not been emphasized. I might repeat some things as we go along, because in 2 days a lot of things have been said. I want to put some perspective on what we call the human factor, because in the last 2 days I've heard a lot about technology and all those issues, but we must ask ourselves, what is the role of the human factor in terms of contributing to patient safety? And as a way of introduction, I perhaps, as has been said in the last 2 days, for the fact that we are all gathered here and the fact that it's the 4th Patient Safety Congress highlights the fact that it's a very important concern in the healthcare system, and we can no longer downplay it anymore. Traditionally, there are 2 ways of looking at patient safety. There's what we call the person-centered approach or the system-centered approach. And I think from what I've heard in the last 2 days, perhaps the system-centered is what a lot of us are still doing. And maybe it's about time we thought of how to balance these 2 things. Now, when you look at person-centered approach, the focus is on the individual who offers the service. And now let's focus on the person-centered approach, because this then addresses what we are calling the human factor, which I think, in my opinion, is a very significant aspect in terms of preventing unsafe of events in patient care. Now, when you look at the human-centered, person-centered approach, you want to look at 3 aspects. Number 1, do they have enough knowledge to do what they're doing? And this is what we call the knowledge-based. Number 2, are they able to follow the rules that have been set by the institution or the system? And this is what we call the rule-based. And number 3, skills-based. And the question is, are we having people who have enough skills to be able to undertake what they're doing so that the patient is safe and the patient lives there satisfied? Unfortunately, or is it fortunately, this approach implies that there must be specific deficits in an individual's knowledge, an individual's ability to apply procedures as set out, or specific or lack of specific technical skills. And the next unfortunate thing is that because we emphasize so much on this, we typically want to find solutions in focusing on retraining, on providing extra supervision for these individuals, and in disciplinary action. One of the biggest glaring things I've noticed here is that the regulatory authorities are probably very scarcely represented in this place. And yet, when incidents occur in institutions, they're in the forefront in terms of wanting to mete out punishments or whatever it is that is there. Perhaps it's time that we also involve them significantly to understand some of these things. But even as we talk about this, it's very important that we must take note that patient safety is affected by a multiplicity of factors, and the last 2 days of presentation have pointed to this very clearly, that there are many, many aspects to patient safety. And I'm going to project a table that talks about things that we call the latent risk factors that we need to identify. Now, look at that list of those tables. If you look at, I think 5 out of that, staffing, communication, training, teamwork, and situational awareness, all those are things that point to the person. And the person must be able to do those very effectively for us to be sure that we are going towards patient safety. If we start with staffing, we must assume that we have adequate staffing, we have staff that is appropriately trained, and we have staff that have the requisite skills to do what they're supposed to do. And that ties together with the training in terms of number of years. Then you look at the institution, and you want to assume that you have a
usual space of action, with, on the left part of the slide, is very close to the level of accident. And this is observed everywhere. Can we tolerate that? Probably yes, because due to pressure of the market, due to the pressure of individual concerns, this migration is mandatory. Effective teamwork and communication, very important. This year, in circulation, was published a statement under the American Heart Association regarding teamwork in operating cardiac surgery. So everybody had to use this statement in the operating room. And in fact, if we observe the impact of debriefing on human factor in cardiac surgery and critical errors, you can see that there is a significant decrease. This work was performed in our institution. SWOT, improving communication between health professionals, nurses, surgeons, physicians, will be very important. However, the problem is that mortality remains high. Last year, it was published in Lancet, a survey regarding mortality after surgery, and it was incredibly higher than anticipated in Europe. Crude mortality varies widely between countries from 1.2% to 20% for standard surgery. No cardiac surgery, no neurosurgery, no transplantation. these data are incredible. After adjustment for confounding variables, important difference remained from 0.44% to 6.9%. So these data are terrific. Why? If we consider the medical risk, I disagree with the fact that medicine isn't safe. That's not true for some part of medicine. For instance, blood transfusion is very safe. For instance, anesthesia is now very safe with a level of complication around ultra-safe industries like aviation or nuclear industry. In contrast, how can you try to improve safety with so different setting between surgery and blood transfusion? What system for safety in medicine? We have three options. A resilient system based on the individual, and this is useful in very difficult situations. Second system, high reliability organization system. And last one, ultra safe system. The question is, we need
skill pool as well as the thought around how we manage the talent across health and life sciences in our country. She's the founder member of the Healthcare Statistics Council, and she's the chairperson of the advisory committee on accreditation and certification governing. I could go on, and she's founded the Max Healthcare Institute. And the interesting part, and I've heard Shabnam speak very passionately about so many different topics. Okay, I stop now? Okay. So let me stop now and move on to Rohit, who's one of the IITians, and he is a fellow consultant, having spent time with Accenture in India and a place which I would love to be in, which is Turkey. And he spent some more time in Chicago, and currently he was instrumental in Wipro's first overseas acquisition in the global energy practice. So Rohit, welcome to the healthcare world after doing consulting and in global energy, and would love to hear whatever your thoughts are on innovation. And one interesting part for all alumni of Wharton is he's also the founder and president of the Wharton Club of Delhi. Next to Rohit, we have Dr. Bhandari, who's the honorary professor of biomedical sciences, is SGPGI campus of Lucknow, and he's the president of ePulse Line LLC. He is also involved with the Vatikuti Urology Institute, the Henry Ford Hospital, and he has done extensive work in robotic surgical procedures and studies around those. I think in the last 3 years, he's established new robotic surgery programs, and the foundation has supported training of 100 surgeons with the help of 40 mentors. And so we'd really like to hear your thoughts, especially with respect to the work you've done on how some of these innovations are impacting patient safety and clinical quality, and what role robotics will play today and in the future. We have Varun, who's joined us from Gurgaon, and Varun leads the efforts for Becton Dickinson in India. We do understand that India is a key market for Becton Dickinson's growth strategy, and Varun was previously in the provider role. So I've known Varun since his Fortis days, and now he's switched from being a buyer to being a supplier. And Varun did tell me that he would like to share his thoughts first on this particular subject. So what I'd really like to do, so I don't have your profile here. So when you start, can you please introduce yourself? Yeah. So without further ado, I will schedule my little piece after you, Varun. And I think the topic is innovation in this particular area, and I had just thought about probing all of you on 3 aspects of innovation. One is really innovation around process, the other is innovation around systems, and third is hard innovation, and really what your thoughts are. I'm leaving the 4th P, which is people, aside, because that's the toughest one, and maybe we'll spend the last 15 minutes talking about what innovation we do from a people perspective. So Varun, over to you.
So very good afternoon, ladies and gentlemen. When I first came here in the morning, the room was jam-packed, and I realized it is a 625 people audience. I see about 300 now. So Amit, many thanks for the introduction. So let me start with the first statement, which says patient safety is a fundamental principle of healthcare. And I think there is no denial around it. But I've been a provider, as Amit mentioned to you earlier. So I used to run hospitals at Fortis Healthcare, and I do realize that every process in a hospital, whichever P we look at, has some inherent risks. And if we were to ask each other on the delivery platform, I think we can't deny that. Further, when it comes to innovation as a subject around patient or clinical developments, I just wonder or just wish if we could, take an office, paint the walls of that office pink and blue, and say that get 10 people in and say start innovating. But unfortunately it's not so simple. Innovation is something that is very difficult to plan. I have not seen people who've told me that, okay, we are getting into the concept of innovation and 6 months later come up with a product which is a game changer for the industry. So what I'm going to do, because innovation is a subject which is not very structured, what I'm going to do is, as a part of my agenda, I'm going to talk about patient safety innovation through a few stories. So post-lunch, I think stories will be the best way kind of to engage with all of you. So to me, patient safety is actually three pieces. The first piece is around adoption. So it is not mandatory that you have to innovate each time. If you were to just go and replicate, you'll get it right. And that, to me, is innovation again. If you don't have something in the current resource setting, if there is somebody in the world who does it, and we can just replicate, adoption is the best way of innovation. The other piece, which is the hard innovation, which is the most exciting piece globally, is development. Is around product development, which actually caters to an unmet need globally. And the third piece, the most effective, is operational excellence, operational innovation. This is one piece of innovation that each one of us can participate in. There is nobody on earth who cannot participate in operational innovation. It's actually about doing it better each time you do it. So right from a healthcare worker within a hospital setting to somebody who sits outside, this is something each one of us can bring onto the table. Let me share a few stories, a few examples to kind of elucidate the three pieces that I've spoken about. On the adoption piece, I'm going to cover awareness, training, advocacy, and policy. Awareness to me is the first step of healthcare. I mean, if you can avoid something, it doesn't get better. Curative stages come far later. So we've all heard about hand sanitization. There isn't somebody who doesn't talk about hand sanitization ever. Ironically, this is still one of the most difficult pieces to achieve. So we've been talking about it, and let me ask you a question. Come to think of it, how many of you have ensured that our kids, our grandchildren, they actually know the 5 steps of hand sanitization? I haven't had a school curriculum, so my daughter goes to school, and I haven't seen a curriculum stating that hand sanitization is a part of it. So there is actually a lot of innovation which is required in the space of awareness. How is it that we can make more and more aware? So I'm going to tell you the story about a hospital in Mumbai. And this hospital, I've known the hospital because I served in the healthcare domain earlier. So what this hospital did, they actually wanted to work with the community, so they picked up hand sanitization as an agenda. They went to 100,000 students across the city of Bombay, and that's massive. But when they came back, each time they had a story to tell me, they told me, we went to 100,000 kids, but I don't think everybody learnt it. I said, you get to 100,000 kids, that's the kind of effort you bring in, and then people don't learn it. And most of the sales guys, most of the marketing guys would turn up and say, I don't think they've learnt it. So what they eventually did, they got 3,500 kids together in a mall, in a shopping mall. And that shopping mall was just outside the city limits of Mumbai. These 3,500 kids sanitized their hands, proper 5-step sanitization, in 55 seconds. And this went on to become a Guinness record. Once it became a Guinness record, each one of those 3,500, they had perfected the art of doing it. Each one of the 3,500 actually believed they were a Guinness record holder. When next day the media actually took it to the newspapers, the 100,000 who had learnt it said, oh ma'am, oh mom, I've also done it. I was a part of the same campaign. So I'm also one of those 100,000 people who achieved this Guinness record. And then subsequent to the promotion, the wave that the hospital created, I think it was not the 3,500 people who learnt the art of hand sanitization, but the entire city. And this to me is an innovation to develop awareness. The next piece that I'm going to talk about under your adoption agenda is something called training. So I've known hospitals from within and from the outside as well. So from within because I used to work there, and from the outside in my current role. And I can tell you safely that no hospital is perfect. There is one hospital which does 5 things better than the others. There's another hospital which does probably 3 better than the others. And how do we share with each other apart from these platforms? So what we've devised, and this is what we do in my current company, we do something which is called signature solutions. It's nothing that we have to teach you. It's a very simple piece of the 4 S's that we really talk about. We interact with all of you in our capacity. So by virtue of that, we seek, we solve, we sustain, and we share. And this is very simple. And we call it the signature solutions. And for those of you who are in the healthcare services domain, let me just tell you, it comes for free. So there is no charge around signature solutions. The repository that we've created on best practices in almost every domain in a hospital, which includes patient care, which includes patient safety, which includes healthcare worker safety, healthcare professional safety, all of these solutions are available with us in our repository, and we'd love to share with them as and when you desire. The third piece that I want to allude to under the awareness agenda is advocacy and policy. Now this is a huge concern when I look at India vis-a-vis some of the other countries which are more regulated, which are more protocol oriented. Here in India, we have 50,000 hospitals, and this would be a conservative number as far as I'm concerned. JCI and NABH actually work a lot in terms of standardizing protocols, in terms of ensuring patient safety. But the irony again, I think, I'm sure I saw Dr. Kalra in the morning here, as a part of the audience, he'd be around today as well. So ironically, 250 odd hospitals are currently NABH certified. My sense is about anything in the range of 20 to 25 is JCI certified. But there is a huge degree of hospitals which do not have a certification, and by virtue of that have not been able to elevate themselves to a standard that they want to. So what we have created is another program which is called the Safe Eye program, which comes in for those hospitals which are currently not ready for NABH. This covers chapter 5 of the NABH standards, and we've engaged with NABH to develop this program, and I can tell you that currently we've covered about 200 hospitals, and we should be able to take it by the end of this year to about 300. And programs like these will actually develop a lot in terms of advocacy and policy in the country. So having done my adoption piece, I'm going to come to development, which is a shorter agenda that I'm covering. Development is more exciting. It's much more exciting because it comes to the hard piece that Amit alluded to. We can touch, feel a product and feel great about an innovation. There are some pieces that I've attended where innovation is synonymous to only product development, and we don't talk about the process at all. So I've covered the process piece a bit. Let me just allude to something which is on the development side. And to get to that, let me share a few statistics first. On the maternal and newborn health, there are 10 million women who go through obstructed labor annually. And that's a huge number. 10 million, trust me, is a huge number. If I was to ask you, I'll rather tell you, 2.6 million stillbirths in the world every year. 260,000 women die during the process of delivery. And if this was not bad enough, 96% of that happens in the developing world. The pieces that we've known so far, for those of you who are in the medical domain, we still use forceps. We still use vacuum. And we do realize the consequences these two can have. I won't be wrong if I state that because of these age-old methods of delivery, the numbers of cesareans that we today do is actually more than what is required. Now this has been a huge unmet need, huge. And this is where we've been doing some work over the last 3 to 4 years. And surprisingly, the product development that I'm going to talk about was not done by a doctor, was not done by a clinician, was not done by anybody who has anything got to do with healthcare. It was just an innovation that somebody brought onto the table, and then BD is now working to make that product out of that innovation. And I want to share that product. We call it the Odon I don't know if you have, so I was actually wondering whether I should be sharing a small glimpse of this product and how this is going to simplify obstructed labor. I was in two minds, but then decided that there cannot be a better platform than the International Congress on Patient Safety to kind of show the first preview, and mind you, this is the first preview of its kind in India and globally. So you are today witnessing the first preview of the device called Odon. So Ajay, if you could kind of, it's a 30-second video, won't take long, but it is inspirational as the way I see it. In case some of you couldn't see it, would you want me to play it again? Yeah, so, all right, so can we play it again? All right. Those in the medical domain, does this excite you? You may be wondering whether it's safe, not safe. So let me just tell you and leave it there for now. It is transformative. It will transform the birthing process worldwide. And India will benefit significantly. And I wonder at times, this is one piece, birthing is one piece, that's been perpetual, will always be perpetual. Why is it that we have not innovated in this space? Why is it that all of us can pool our resources together? Imagine somebody who's brought this innovation has nothing got to do with healthcare. He just thought, why can't I make obstructed birthing an easier process? And we'll soon be talking about this in various other forums. Till then, you're the privileged few to have seen this video. So I'm going to be concluding my conversation in about 2 to 3 minutes now. The second innovation that I want to talk about, which is again on the development side, and I'd say patient safety is not complete till I've spoken about healthcare professional safety. Now I'll allude to a research that happened in the US. In the US, we surveyed 1,500 nurses. 41% of them were found to be exposed with some hazardous gases. 42% of those 1,500, if they were subjected to a prolonged use of chemotherapy drugs or prolonged administration of chemotherapy drugs, the probability in 42% cases of having cancer was higher. It's a very simple solution to deal with this. And the solution is a closed system drug transfer device which does not allow the gases, the hazardous gases, when we are preparing the medication, the chemotherapy medication, to go out. It's simple as that. I won't elaborate more on that. I'll leave it here. Soon India will be seeing a product called the Facile, which will deal with this problem and which will deal with the hazards that I spoke about on the healthcare professional safety. The last piece, and probably the last minute of my conversation, is something that is large scale, mass scale, can actually transform, and that's called operational innovation. So innovation is not a word that we have to run away. Innovation is a word that each one of us can adopt. And if I was to translate operational innovation into another parlance, probably I'll say continuous innovation. So I used to work in this hospital where, and in fact every hospital has this ICU. And in an ICU, more often than not, you move in a patient to a bed which is vacant. You move in a healthcare worker, base the roster. Now somebody just came back with an idea in one of the ICUs that I used to work with. And the idea was, so we capture the Apache scores. And I understood what Apache was that time. It's a measure of criticality when the patient is coming into the hospital. So we capture the Apache scores. Why is it that we can't use it to optimize resources on the patients who need it more? So when the patient actually comes into the ICU, why is it that we cannot deploy the best nurse for the most critical patient, the best bed, the highest level of equipment for somebody who needs it more? And then this hospital started to deploy this. They started a program which is today known as the CCNP, which is called the Critical Care Nursing Program, and trust me, has been a best practice. I know that nobody from the outside world came and told that nurse to do it this way. This was something that that ICU brought, that one nurse changed for that hospital, and which is what I term as operational innovation. And I hope that each one of us are able to contribute to the patient safety piece through the operational innovation in our labs. With that, thank you so much. I shall be taking your leave because I have a flight to catch. And Amit, thank you so much for the opportunity.
Sorry, I'll just step here because those mics don't seem to work. Varun, thank you for such a fantastic speech. All I can say is, I think Varun has stolen the thunder from the iPhone 6 launch on the 9th of September. So, I want to pick up on the last point Varun mentioned, and I think that gives a good segue to inviting Dr. Shabnam into this conversation, which is operational innovation and how a nurse actually made a tremendous difference to how the old standards around patient safety and quality improved. And it's almost a dilemma to my mind, where in such a top-driven organization, how do you foster innovation and pull it back into the ethos of the company?
Thank you very much for having me here, and I'd like to disabuse everybody of all the kind words that Amit said about me earlier. While in 34 years, yes, that's exactly the number of years that I've been in healthcare, and I have seen this entire piece of corporatization of healthcare evolve. We've come a really long way from what we were and where we are. But at the end of the day, nobody at any point in time would like to hurt another person willfully. You've got to make a system perfect, and that's where the problem lies. The system is not the person. It's something you happen because we couldn't afford to get into the JCI club. Why did the JCI happen? It was impacting how you could differentiate a superior level of service in the United States, and then everybody wanted to copy it. Look at all the 3-4 different pieces that I was able to pick up. These all have an element of what's in it for me. And that what's in it for me was, how do I address from a management perspective, my turnaround times are good, my stakeholders at a management level are comfortable, the patient who's is the key to my success and why I'm here, he should be happy, therefore when he goes home or she goes home, I'm going to give them a call. And I'll share with you what Amit requested as to what did we do as far as Max Healthcare was concerned. People are expensive. People make the physician part of this? How do you make the management part of this? There are only two ways in which you can make people think the way you do. Either you incentivize them or you penalize them. Incentivization in a cash-strapped environment is the most difficult thing to do. And that is the question I leave here for this international conference, and I would request Amit to see whether this can be taken forward. And that is, we turned around and told everybody within the system that if you don't follow and punch in the CPRS, you are not going to get your paycheck. You'll get it, but you'll get it 15 days later after the EMI of your house loan hits your bank account. So we couldn't stop it, we could delay it, which you're willing to share, and then benchmark yourselves across that in a global fashion. That's when the needle is going to move. Till then, we'll still come back, we'll have the 5th and we'll have the 6th, but we won't move. This is what we adopted when we tried to change the mindset of looking at skilled people in healthcare. That platform, ladies and gentlemen, has to be created. It has to be now. You can't constantly have protectionism and come back and say, I can't tell my nurse, I can't tell my doctor you did this. Somebody very rightfully said that one of the ways of addressing a surgeon who would repeatedly do something was, you like the 8 to 10 operating slot, buddy, if you don't get in line, I'm going to give you the 2 to 4 slot. They're small things, but it has to come out, and collectively it's going to happen. Thank you so much for having me here.
Thank you, Dr. Shabnam, for such a passionate discourse. One example came to my mind at Virginia Mason, where as part of the whole turnaround process that they went after, they encouraged everyone to log any kind of adverse event or anything they felt out of ordinary that was happening. In the first month, they logged 1800, and after 24 months, they have anywhere between 600 to 800. It still is there, but the mindset or the severity of the kind of events that have started to being logged have changed dramatically over time. And if you can't measure, you can't manage. One is about disincentivizing and penalizing. The other is, how do you encourage people to actually across levels open up and provide feedback, information or innovation across the whole channel. On this note, I'd like to request Rohit, if he could come over, talk a little bit about your company as well, Rohit. It wasn't included in your brief. We have time till 3:40, so would request the remaining panelists to spend about 7-8 minutes so that we have 5 minutes for questions. Thank you, Rohit.
Thank you. It's a pleasure and an honor to be here with all of you today. I'll start with Elsevier. As you know, is a 400-year-old publisher. We started in a different form where Galileo published his manuscript about the earth going around the sun, and he got placed under house arrest. That was a predecessor company to the current day Elsevier. It was then called Elsevier, and the current day Elsevier is about 130 years old, and it actually has been a delightful journey for me personally over the last 5 years in actually being a part of the healthcare industry in India to play a vital role. And you know, in some ways I'll also start with explaining what a publisher does and my interpretation of that. A publisher is actually a group of individuals who actually take information which is in the hands of experts or in the minds of experts and bring it to the people who need it. And historically it was always done through print books, through getting books available to people in the libraries, to students when they needed it. But one of the main innovative changes in using technology that has happened is getting the information at the right time. So today we still have issues with school books. You know, our children are in schools start, the books haven't reached the bookshop. This book will come 2 weeks later because of demand-supply imbalances. Now when you look at patient safety, can you imagine that you've ordered training manuals that haven't come in the hospital at the right time to train all the hospital administration staff on how to create a simple awareness about a simple training that could have prevented lots of errors from happening. And I think that's where technology comes in, and that's where I'll talk a little bit about sharing some thoughts with you about Elsevier. These slides up. So I think in the interest of time, I'll skip through some of the broad context setting which has been done over the last couple of days. But fundamentally, there are three aspects to patient safety. It is what happens before they're hospitalized, what happens in the hospital, and then what happens after discharge. And there are different pieces of information at each of these stages where we can play a role. I don't know how many of you have heard the joke about the doctor's wife couldn't read the love letter, so she went to the chemist, because only the chemist could understand the handwriting. And I think that's where there's some challenge comes up of why sometimes a doctor from outside the hospital refers it to a different hospital. There are some prescriptions there. How is that actually all interpreted eventually? And when you start seeing the human changes that happen, that's where the error comes in. And if that can be automated, then you actually see that information flow happening with hopefully less errors along the way. So a lot of this is around innovative data collection and patient safety guidelines, and then really incentivizing, as Dr. Shabnam Singh talked about. So I'll focus on the area where we as Elsevier now play. Most of what I'm going to talk about currently doesn't exist in India yet, in the sense we haven't brought some of these things to India. What I see, however, is an opportunity to look at this and then create with the Indian healthcare ecosystem some software like this. So in a structured care program, we have a software which is part of our drug database where the alerts come up if an important drug is to be given. In the context of the superbug in India and the use of antibiotics, this becomes very important, because this is highlighting you are actually giving a very, very important drug which should be used with care. So that's some alerts that pop up in the system, and this is being integrated with our clinical key product, which a number of hospitals in India have started using. On the other side, and I'll skip to just the graphic to just talk about this. So there are 3-4 areas where we have invested in building products. In order is a product around order sets. And I'll share an anecdote that about 4 years ago, we got a call from a US offices to ask how many hospitals were using order sets. And that time there was an interesting company in the US that we were looking at acquiring, which had actually created at that point about $40 million in revenue from order sets. And what we found out from about 10 different hospitals that we surveyed through either our authors or people we knew, that nobody was really using any product on order sets, but it was being created in-house. So protocols were being created, they were pasted on the notice boards or pasted on the boards where the doctors were, where the nursing stations were, but there was no automation around it. So order sets is one area through which, if you actually get the process flow mapped, then the right alerts come to the staff who is treating the patient at the right time. So actually some errors are corrected. The second is that our company has acquired an organization called Exit Care in the US about 18 months ago. And Exit Care is about post-discharge care and what to do at the time of care and what happens after the care and how to monitor that. So it's an automated software built for the US context can actually be applied to the Indian context with a little bit of customization and adaptation. So those are areas where we see that very quickly, some things that can be automated can help improve patient safety. Now all of this innovation, as you can see, some of it is happening inside a publishing company. Sometimes it's happening outside a company. But publishers increasingly are becoming information providers, because all we actually do is provide the right information, hopefully at the right time and when you need it. So that role is now where technology plays an increasingly important role in the context of patient safety. Getting the right information at the right time becomes the most important prerequisite. So with that, in the interest of time, I'll sign off here. Thank you very much.
Outcome of surgery is, it's not enough that the patient is alive at the end of the surgery. I'll give one example. Robotic prostatectomy's learning curve, according to the company, is 10 patients. For an accomplished surgeon who is transiting to robotic surgery, the study we did, we found that it's okay. In 10 cases, he would be able to complete surgery without any intraoperative complications. But in order to benchmark the positive margin rate, which is directly related to the recurrence of the cancer, he needs to do 300 cases. Now, question we need to answer is what happens to 299 patients. And that's why I would say the surgical outcomes of the safety we have to assume is a zero tolerance. Is a zero tolerance. Is besides the point we are adequately prepared to achieve those targets or not. To a new technology. So like I'll give example, I was having a conversation with one of the top esophagus surgeons who does about 1,000 to 1,100 esophagus a year. Technologies for learning curve. We were very concerned when we first what we did was we looked up extensively the literature. How do we monitor first 10 patients in our hands? And kidney transplant. Key point is the warm ischemia time, how much time you take for the anastomosis. And when you are doing first time anastomosis with the robot, you are likely to take more time. So we built the safety net assuming that there would be more time. So we added hypothermia, which gives you ample time to do this technique. But then still we monitored that moment the Shivard charge went out of the control. The expert surgeon went in who had experience of doing it. The point I am trying to is with almost 15
I think of the last minute add to the panel. So my name is Kshitij. I am from the Harvard Medical School and the MIT Media Lab. I lead HMS BCL and the Media Lab's India program. And so my talk today will be about technologies in healthcare as we do at Harvard and MIT, and give you guys a peek into the future on what lies ahead a small snapshot of this. So this was the first, 1 minute. So this was the first digital computer done at MIT in 1955. It was as big as the size of this room. About, I would say, 14 years down the line, the first computer put the man on moon was about 43 kilohertz, 64 KB of RAM. And then companies like Intel, Fairchild kicked in, Moore's Law kicked in, and we saw massive growth in computation power. What that actually did was reduce the cost of innovation in this field of computing and technology. And now the device that you have in your hand is about 1 million times faster than the computer that put man on space. What we see at Harvard and MIT is an interesting parallel happening in the field of healthcare, with the first genome sequence that, again as big as the size of this room, took days and days to compute, to what you have right now, which is some orders of $1,000 genome sequencer. And the very interesting part about this is that the cost of innovation in healthcare is going down very rapidly, and we know much more rapidly than it was happening in computing, and which opens up a lot of questions, needs, challenges, opportunities in how would technology with this rapid pace actually transform healthcare in the future. The two parts that we work on both at MIT and Harvard is a part of healthcare sensing and how to use that sensor data to do a lot of big data analysis. Let me give you a sneak peek of some of the technology that we see you might end up seeing in the market in the next 5, 10, 15 years. So imagine a camera that can look around the corner. I can just shoot a door and I can know what's inside the room. This is something that we did at MIT about a couple of years back. What we're working on right now is taking this technology and putting into a mobile device or an endoscope and seeing, can we look around tissues, arteries, and how can this impact healthcare? Now maybe in the previous decades might take 10, 15 years, the pace at which tech is changing, you might see something like that coming out in the next 5 to 10 years. If you've ever gone for eye test to an ophthalmologist, I mean, this is something that you go through a simple phoropter, and our idea at Harvard was, can we create a mobile application or mobile add-on that can give eye tests with a normal phone? So what we made was a technology in which you can just keep your phone at arm's length. You can see a few numbers. You pick the number that you see, and what you get back at the end is a spherical and the cylindrical number of your eye. Again, trying to see how, whether this has been made possible because the cost of technology in mobile devices have gone so low that the pixel resolution on a 500 rupee phone is good enough for us to compute your eye number. This one project that we did again at Harvard Medical School, the idea was that we went in ICU and we saw nurses with so many pieces of equipment around them and tried to monitor each part of it. And what we thought was, how can we make for nurses and doctors easy monitoring of patients? So we converted all the signals that you see in an ICU into musical notes. And the whole idea was that if a patient is not sick, he's healthy, then the music sounds good. And if the patient's vitals are off, the music goes off. And if you're an amateur musician, if you hear music, I think you can make out which chord has gone off and maybe go back to the bed and treat the patient. So we called it the Musical Genome Project, and we actually went and applied the same thing to cancer cells, and we could find change in notes in terms of if your cells are normal or cancerous. One of the last points I'd like to talk about is this ability to actually refocus or capture in 3D after you've taken a photograph. Now suppose I click this photograph, what we were able to do is by printing a simple transparency out, putting out on camera, taking a photograph, we can change this picture to this picture. And we're able to do that because the technology can help you capture 3D information. The next step, we put the same camera on top of a microscope. And for the first time, what we could do is, using a simple microscope, get a 3D image of the cell, in this case, a wax crayon. So these are the kind of technologies that we are working on at Harvard and MIT. I think in the interest of time, I'll just skip a few slides. This was one thing called the medical mirror. The idea is that what if a patient can keep track of its health on a day-to-day basis, has a camera behind, tracks your face, and can give you your heart rate and blood pressure right onto the screen. So when you wake up, you're brushing your teeth, just check your heart rate, blood pressure, and boom. Big data, of course, I mean, we've seen a huge growth in data in the last 10 years. Every year, about 500,000 new biomedical articles come back into the medical literature. And one project, briefly mentioning, we could take all the data from different parts of sources, Elsevier being one of them, and we're able to collate various terms. And this can help the doctor or the patient to make sure that the best practices or the best terms in diagnostic and safety and care can be made available on a real-time basis with just-in-time technology. Finally, this is the big chart that we see that you're going to have with this the cost of innovation becoming very low in healthcare. A lot of data, devices, sensors that you will be adding on to your lives to capture information, and all of this will be available onto the cloud. Various companies, startups, doing analysis, learning, and giving you the data back so that you can have a better know-how of your life and of your health. Thank you.
Kshitij, this was fascinating. My only request would be if we could in some way send you our wish list, and with a price tag of not more than $1 to $5 for all the technology that we could deploy here, because there's just so much that is needed across everything. I think we're running out of time, and Sujay, I just wanted to check the presentations would all be available to the... Okay, so there was one particular thought leadership we did on as KPMG globally on clinical governance and quality. I've not had an opportunity to present this given the time, but the soft copy is going to be there in the presentation, so do have a look at it and let me know if you all want the detailed copy of the report. At this point, thank you very much to the audience and to the panelists for sharing such wonderful insights. Do we have any time for questions? Or no? Are there any questions anyone has? I know we've got a break also coming up, so we'll all be around in case you all want to talk to us and put in the wish list to Kshitij. Thank you, you all have been a wonderful audience. Thank you for your patience, and thank you, panelists.
Excuse me, it's just a simple question from the respected panel. Ma'am, all these safety things we talked for last 2 days, but we didn't put any concern regarding the government hospitals. Looking at the proportion of patients we attend in the government hospitals and in the corporate sector, I could not find any rules, any policies, or any type of things for Indian population particularly. Besides India, we could see people from other countries had any points for the rural, for the interior patients. But for our Indian population, I could not find any points. Can please give any light on this point? Because NABH girls, the corporates, what about government sectors? They are just left as such.
I can legitimately answer this question because I spent my 40 years in government institutions. And I concede to your point that things are beyond your control. You deal with humongous volumes. At one time, in one particular institution I was heading, we banned extra beds, and there was such a hue and cry because there was no other emergency in that town. So, but only my message is still you could be as safe as possible at your personal level. You can't ensure the whole system because it needs augmentation of facilities, it needs change in work culture, it needs change in mindset, but as an individual, you could still contribute a lot in doing things right and making them as safe as possible.
Thank you, sir. So just a point, because I'm standing in front of so many people who have high homes, so it's a request that if possible, people from IMA or NABH, if ever they can put points for these government sectors also from their behalf, it will be a great help to the healthcare personals, doctors, particularly we people who deal with infection control. I'm a microbiologist, but each and every day I keep struggling with every clinicians, convincing them in this patient safety regards. So it's just a request if any of the high hands can do anything for the government sectors. Thank you so much.
Amit, I'll just take it for a second. There's no need for you to feel so despondent. So I sit on the NABH board, right? And absolutely right, everything that was said earlier, that there are only X number of people, the hospitals which have been NABH accredited. Dr. Kalra would have told you that in our last NABH board meeting, we've put the standards for small and medium which are focused on the government sector. So they're contextualized to India. That's one point. Second point is that there are 2 government hospitals which are NABH credited. And the third point was what I mentioned in my piece right at the beginning. It's up to all of you, government and private, to pick up 1 or 2 patient safety points which you would like to have in the open domain, and then benchmark yourselves. Don't set yourselves up at a very high level. Nowhere in the world in the United States, they're taking baby steps at sharing information on morbidity and mortality statistics. That does not mean that we can't do it in India, but it's up to everybody here to do it. You have to identify it, what works for you in the government sector, then the rest will follow. So take it upon yourself to make it happen.
Hello. I want to share for this. I am a person coming from the government sector, served for 25 years in the capacity of the class 1 RMO and civil surgeon. Let me tell you all Indians that our all Indian hospitals, which are the district hospitals, they only create all these doctors. All these medical colleges, whatever district hospitals are there and medical colleges which are dwelling in the India, they are producing the best of the best doctors and the best in the world. What I want to say, now this NABH, NALA has come out, only it is from above, we are working from below. All the quality, all the good things are with our government hospitals, medical colleges. For example, let me tell you myself, not to raise my image, is that I was working at the district hospital Ratnagiri, 250-bedded hospitals. I have done personally more than 300 cancer surgeries. In the district hospital setup, I have done more than 100 oral cancers. I have done more than 12 esophagus surgery. Don't you think that I am a producer of best doctor from my medical college in the India, which is running in the rural hospital? So be hopeful. We are the good. We will be the best in the future.
So thank you. Thank you for being a wonderful audience, and thank you, sir. Point totally noted. I don't think there is anything different, and I don't know why we keep drawing this huge line. It's a problem for all of us. I don't think it's a public problem or a private problem at the end of the day. Thank you very much.
Hello. On that exciting note, we bring an end to this session, and I would ask Amit to please hand over to hand over the mementos to the people who spoke, And if you could kindly hand over the mementos to Mr. Rohit Kumar, Dr. Shabnam Singh, Dr. Mahendra Bhandari, and Mr. Kshitij Marwa. Thank you, everybody. Thank you for the new insights into innovation to help in patient safety. And we will now move over to the next session, which are the parallel sessions. And at the outset, I would like to mention that there's a session on infection control, and that is happening at the Pala room, which is on the first floor of the hotel. And we will continue over here with the session on medication safety. Thank you, ma'am. Thank you, Kshitij. Wonderful. Great listening to you. Thank you. Thank you, sir.
Thank you, sir.
Thank you, Amit. Okay, that's it. And our DMS, Dr. Dipankar Ganguly, has told me specifically, please do mention, Shaikat, that I am over there as the chairperson and I am conducting the infection control at Pala. But over here, I have the pleasure and privilege of inviting over Mr. Jagdeep Singh, who's the MD, SPS Apollo Hospitals, Ludhiana, and Dr. Shweta Dhawan, the lead on special projects in quality of the Apollo Hospitals group, to kindly chair the session on medication safety. And the speaker for this session is Dr. Paul van Ostenburg, and I would request the chairpersons to kindly introduce the speaker. So it's on medication safety.
Good evening, everyone. We are more or less coming to the end of the conference. But what makes me feel good about is that it's ending on a topic which is so very important, medication safety. I've been attending this conference since yesterday. But there are two things which really are firmly etched in my mind, and they've been very disturbing. Yesterday somebody was giving a presentation and he said that methylated spirit was taken on as an IV fluid. And the second was a neonate being given anesthetic relaxing agents. Fatal consequences in both of them. So we can choose to ignore medication safety at our own peril, at our own risk. But most of the organizations have come to realize how important it is not to ignore it. It's my proud privilege to introduce Dr. Paul van Ostenburg, who's been associated with JCI since 1998 and was responsible for setting the standards, for formulating the standards for JCI evaluations. He's had an illustrious career in the JCI, and he led the development of international standards and survey methods in promotion of accreditation around the world as an effective quality tool. In 2014, he was appointed Senior Advisor for Global Growth and Innovation. The other person is Dr. Shweta Dhawan, who is a lead assessor and has been a very close friend and an associate and has helped us during the course of our accreditation. Dr. Paul van Ostenburg, please.
Well, good afternoon to all of you. You have stayed through the last 2 days, over 50 speakers that we've all had the pleasure and privilege to listen to and learn from. So you might be asking, is there anything left to talk about? Good question. Because what you'll see in my presentation is the repeating themes that you have heard yesterday and today. The themes of change, the theme of communication, the theme of leadership, the theme of a culture of safety. So what I'm going to try to do is take some of these themes and embellish them in relationship to medication safety, and then expand a little bit with some ideas on medication safety. Now, full disclosure requires me to say that I'm not a pharmacist. I was trained as a hospital dentist and an administrator. And yes, I do know about infection control standards for accreditation. But I've had to have a colleague work with me on this, Janelle Mansour, who's our infection control leader. And in planning this presentation, we realized that if we are going to, as clinicians and hospital administrators, nurses, doctors, face patient safety in the future, we must think in a different way about medication safety. We must look at it as a system. So what you'll hear me comment on repeatedly is how to take a look at medications, not as a pharmacy plus some other things, but as a system in the hospital. So that will be the focus of my presentation. So, yes, we've seen lots of slides on patient safety consequences, things that went wrong. It's true, but let me talk about that just briefly with you to give you a little bit different perspective on it. And then I want to take a look at some strategic imperatives that relate to leadership for medication safety, and then the system's approach to medication safety. Now, we know that we've really raised awareness of medication issues. We have, as far as I understand, we've created a lot of patient safety tools and ways of improving medication safety. We know that internally in the hospital. So, when you look at the 1999 publication of To Err is Human, and you have seen this cover on probably 5 different slides already, but that one goal that was stated in the book was a 50% reduction in errors in the next 5 years. But we are 15 years after that. That would probably be possible if the healthcare system didn't change, if patients did not change, if practitioner skills and knowledge did not change, if our tools did not change. But all of this, and as was said in one of the opening presentations, the only constant in all of this is the change. So let's just take a little bit different look and say, what is changing? So are we losing ground, or are we creating the tools that will help us face a different today and a different future? One of the things that I'd like to just point out is our perception. We have raised awareness of medication safety issues. I'm not sure the public has the same type of awareness. If you look, for example, at this was 3 babies that were killed because of look-alike, sound-alike medications. This gets in the paper. Do the individuals looking at this article really understand the complexity of look-alike, sound-alike medications? It's far different than going to your cabinet in the kitchen and differentiating between thyme and oregano. It's a very different issue, and I'm not so sure the public really understands the complexity of that. I think within healthcare we are finding that. I don't think the public understands that so many of the medications we use are compounds, and they're put together. And this does not get in the paper very much, but if you look here, there's a lot of compounding errors. 5 patients were treated with a drug, Avastin, for eye disease and have been blinded. Deaths in Alabama from a contaminated supplement. Deaths from an intravenous drug that was compounded in error. Hospitalized infant dies of a zinc overdose. All of these are compounding issues that I think escape the view of the public, except in the United States. That changed last year because of a compounding problem in an organization in the Northeast that their pharmaceutical compounds were used around the United States. Suddenly you had Dr. Besser on Good Morning America talking to the public about this compounding problem. So to the national scene, and the public started to understand that a lot of their drugs are put together. They're not manufactured in plants they're aware of by the big pharmaceutical companies. There's intermediaries that are putting these drugs together. So the heightened awareness. Now, I'll be a little cynical. What happened from this is Washington and the politicians say, well, how can this happen? And if you look at all the states in which patients got fungal meningitis, this touched on a lot of congressional districts and a lot of politicians. So what do? They put laws and regulations into place. Did that solve the problem? I'm not so sure, because most of those laws and regulations will take 5 or more years to totally get into place and make a difference in the industry. But is this in the newspaper anymore? No. We don't hear anything more about it. The public thinks that the issue has been fixed. We know in healthcare that compounding is still an issue. If you look at this particular event in which there's twin babies were being treated for a staph infection and were given the wrong drug, and fortunately they did not die, they got better. Well, we know that those kinds of adverse events and near misses every day in hospitals. In this case, it only got into the press because the parents, the father in particular, Dennis Quaid, was a well-known American actor. But public doesn't understand that these are serious events that occur daily in hospitals, and this article becomes a sensation. Also, the reporters use language frequently that excites the public, but doesn't really add to the debate. The UK is great at using language occasionally that's a little inflammatory. Here it says, a blundering nurse. I'm not sure many people would really understand what a blundering nurse is, but anyway, it's certainly derogatory, and we know that this was a nurse that didn't intend to blunder that day. It happened, probably because of a system or process issue, but then they capitalized 10 times the dose in big capital letters. So we have a lot of sensationalism. So I think my comment from this is we have a long way to go to help the public understand that this is a serious issue and that hospitals are working on medication management and better error reduction, along with better reporting, of course. So that's a larger public challenge, but there are some other challenges I'd like to talk to you about. Advances in medical technology are just astounding. This last presentation just on the technology that's coming down the line is just mind-blowing to me, who grew up in a totally different era and is not very technologically savvy. It's wonderful. We also heard about, from Medtronic, about the insulin diffusion devices that are implantable or external with telemetry, monitoring. And we heard about also from Medtronic about these little packs of antibiotics that can be implanted into the body, and it dispenses the antibiotic over time and the packet dissolves. Now, I'm kind of a detailed person, and when I hear about something like that, my initial reaction is excitement. You know, we know that a lot of technology has come along. We've had artificial hearts for quite a while. We understand the drugs that need to be the rest of the life for that type of patient. We have a lot of people with serious injuries and bionic parts. We understand medication management better for them. We understand the medications that are used in the very complex operating theaters. But when we hear about some of the new medication advances, we need to bring that back to our pharmacy departments, back to our leaders, and talk about them. I think with those medication antibiotic packs that are inserted, is that a supply that's held in the operating theater? Is it in the pharmacy? How do you write an order or prescription for that? How do you monitor the effectiveness of that? For the infusion pumps, that through telemetry, who's involved in making sure that it's the correct dose, that's still being delivered to the patient? What is the whole medication management role in that type of device? So, yes, we need to welcome those devices, but we need to be very clear about the roles and the role of the pharmacists and the clinicians in managing these types of advice. The second challenge that's coming to us is emerging infectious disease. Now, I'm sure they're talking about that in the breakout section, but there's a couple of things that I'd like to point out. First, we are certainly aware of hospital-associated infections. We've had a great deal of time to identify them, to develop protocols for treating hospital-acquired infections. I was at a conference, and an individual came up to me at the break, and they had a mischievous look in their eye, and I said, "Do you have a question?" They said, "No, I just wanted to tell you that we cut our hospital infection in surgery or with a medication or so." The traditional answer was, "I tell the nurse." You talk to the nurse and they say, "What do you do with that information?" "Oh, if I have time, I put it in the adverse event reporting system." Well, that's unacceptable, because in hospitals with thousands of trainees, you have a very partial picture of what the events are occurring in your hospital. I have talked to many research directors and research departments in academic medical centers, and I say, how many of the research protocols have adverse events with them, and what type are they, and the frequency? We're not sure. You talk to the quality department and say, "We don't know." You look at the telephone number on a medical record of who to call if the patient seems to have an adverse event, and it is some kind of intermediary managing the research, or it's the pharmaceutical company. It never goes through the quality department. You talk to the principal investigator, they have hundreds of adverse events in these patients in beds in hospitals that are in research protocols. No one can really distinguish between what's related to the trial drug and what's related to the other drugs in the regime that the patient is on. So we need, for those of you who have clinical research going on, make sure that it is well integrated into your quality infrastructure. There's special challenges for medication safety today. Much of it is the suboptimal use of current technology. A lot of it is the fact that what we do have, say if you have software that does drug interactions or drug-food interactions, do you know that that's the latest software? Most people don't. And they may be 3 or 4 versions behind on the software. It's the same as with biomedical equipment. If you've got infusion pumps with software in it, do you know if it's the latest software? And do you know if the latest software was put in, if it changed in some way the calculation of the dosing? And so we have to better integrate the whole idea of software and technology into the medication management system. You saw this quote this morning. The quote was made in 1999, the same year that The Air is Human came out. And I think that if you change the date on this to 2020, it would still be applicable. We are making advances. We will continue to make advances that add to the complexity. And we know from experience that tight sequencing of things that are in a hurry, the complicated and intense processes are a setup for patient safety issues, but yet that's the direction we're going, is more and more complex services. Now, think back to that aging patient with multiple chronic conditions that may be on 15 different medications. This is the communication that has to occur to discharge that one patient. Over 250 communications among the practitioners and departments to get ready to discharge one patient. Multiply that times 10 discharges a day, and you have thousands of communications that have to be managed. If you just look over there on the far right, about at 2 o'clock, you can see the pharmacy. Pharmacy is communicating with the patient. Pharmacy is communicating with a lot of other units. So this is reinforcing the fact that many people throughout yesterday and today have talked about the need for clear communications. Is there an electronic answer to this? Possibly. Is there a training answer to this? Partially. There's no single answer to this. It's elevating communication to the level that is a critical system in an organization, and paying attention to all types of communication. Patient communication and other types of communication between staff members, communication in terms of transitions of care, etc. Now, the medication reconciliation process was really a neat idea. You know, patients coming in on multiple medications, moving within units in the organization, being discharged. Who knew the whole picture? And so we created this medication reconciliation process. This did not go well in the United States. I will tell you, it took a long time to get any traction because it was looked at a new process, not a communication process. It was looked at something to track drugs in pharmacy. And the comments came back. We don't have the money to hire somebody to run this medication reconciliation process. It's too complex. Our records don't support it. So it was seen as an add-on step. It was not seen as part of basic communication regarding a patient and their medications. So if you look at this and what happens at discharge, it's very clear that the different evidence shows that the rate of adverse events post-discharge are fairly high. If you consider the fact that a patient is going home, they remember all this stuff they were told about their medications, when to take them, but nobody told them to throw away the medication that they were taking when they were admitted to the hospital. So they may have been given that same medication as part of their discharge package, and they pick it up at the pharmacy on their way home, and then they think, oh, I've got all this medication I was taking before I went to the hospital, so I guess I should still take that too. So we have very incomplete discharge instructions. That's part of medication reconciliation, but the education for patients to get them to actually do what they were told to do needs a lot of work yet. We need better support for patient understanding of how to take all their medications and give them, there's various assistive devices, but most of those are not coming from hospitals, they're coming from the neighborhood drugstore, from a family member, or something homemade to help them know when and what to take. So what are some of the strategic imperatives for medication safety? Leadership, no surprise. For all of patient safety, we have said that the leaders have to be personally involved. And Karen Timmons talked about this. Paula Wilson talked extensively about this. And I'm just going to make a few more comments on it. But there is plenty written about the importance of leadership. Joanne is certainly one of the most respected quality gurus in the country. So I will share with you what I believe are the 4 challenges for leaders right now. And again, Paula Wilson talked about creating a culture of safety. Now, we have to really understand that, first of all, leadership needs to truly understand what a commitment to building a culture of safety involves. And Paula talked about this. She talked about a just culture. A just culture didn't ring really true to me until I was admitted personally to a hospital very late in the evening with an acute problem, and I needed arthroscopic surgery immediately. And the physician came in and kind of, was giving me the consent, risk, benefits, alternatives. He said there were no alternatives. And I said, have you had a busy day? He said, my first surgery was 7 o'clock this morning. I said, it's approached midnight. Are you getting tired? He said, no, I'm as fresh as this morning. I said, well, will you be doing the surgery? He said, I work as a team. I said, but will you be in the room? I work as a team. Well, he was really abdicating his accountability to this guise that we have teamwork here. The surgical team will take care of you. I should have been more clear in my question, will you even be in the room awake? But I was in too much pain at that point. Whatever he said, I was willing to go along with it. But we have to really understand the different interpretations of what it is to have a just culture. We need to measure it, as Paula said, and we need to get a baseline of what it is, and not for your entire organization and for different departments. We know what a baseline is. You get baseline hearing tests. You get baseline, all kinds of tests to get a baseline. Well, this is so critical to patient safety, we need to get a baseline there too. The second challenge is to support shared accountability. I like to use, excuse me, here we go. I like to use this visual to talk about shared accountability. It also gives a better understanding of what your quality infrastructure, call it a program, call it a department. It's not at the center of this hub. I've talked to different people in the department and said, well, who has that data? Oh, you have to go talk to the quality department. Or what about this? Oh, the quality department determines that. So the accountability, people were just saying, yes, we do that as an organization, but I'm not accountable, it's the quality department. So This was to try to depict the fact that the quality program is supportive to everybody. They're the ones that take all of the adverse data from everybody and look at it and feed it back to each one of the departments. But you have accountability at every ring in there, all wrapped in accountability to the patient. So it starts with governance, and we know that for terms of the culture of safety, it starts with governance, then to your CEO suite, then to your department leaders, and then out to every one of your clinicians. So, what does this mean, shared accountability for medication safety? Well, it means that if you look at the medication management processes in your organization, you will see it starts from purchasing, which comes in management side, and continues on to accountability on the clinical side in terms of ordering and dispensing. The third challenge is bring clarity to the patient safety and quality improvement process. Now, I've admitted I've been around for a long time. I have as much gray hair as my colleagues in the room. And when I started in the 60s in the hospital, we did retrospective chart audits every Tuesday night. We found very little, we learned absolutely nothing, because the information never got out of the room. The clinicians would say, very interesting, let's go have a drink. We called them liver rounds. So, totally useless. But then we started to get into a more reactive, well, if we know something is bad, quality assurance says we need to get rid of the bad apple. Then we got CQI, we got TQM, we got Six Sigma, we had all of these different ways of looking at quality came into our toolkit. But then if you look at how are we moving to be a more proactive review, we're starting, and you have seen in the slides, I think maybe 6 speakers at least used high reliability as a very proactive approach. When I first started listening about high reliability, and the Joint Commission has done a lot of work on it, to be truthful, I couldn't quite figure it out and what is different. So I went back to James Reason's Swiss cheese model. You've seen that twice today already. But I want to explain what this means to me to be highly reliable. The old method was you looked here, did the event go through the last slice and hit the patient? Then you had an adverse event. High reliability says, we don't even let it get through the first slice. Well, how do you do that? Well, if you have a safe culture, people start reporting small things to you that don't quite seem right. If you look at the wrong side surgery, 20% of the root cause analysis show that it started at the registration of the patient for surgery. So if you get up to the operating theater and you look at the paperwork and say, I've never seen this signature before. Oh, that was a temporary worker in registration. So-and-so, where are they? Oh, they're a little running late this morning. And you start to pick up the fact that there's a number of little triggers starting to come together because you've got everybody giving information and sharing things that they don't think are quite right. And it's that you put all those triggers together and you can stop an event from starting. So that's high reliability, but as you've heard, it takes a very strong culture of safety for people to really start to reporting even those small events. The fact that somebody is late for work because they had a sick child or something is not the issue. It's the fact that the process that they normally work on may be shortcut that day or done by somebody who doesn't routinely do that process. Now, the next thing I'd like to say that leaders need to look at what quality improvement methodology do you use. If you use the PDC or PD Study Act or so, if the leaders see that every department is using some different methodology, oh, cardiology uses Lean and Six Sigma, oh, they use PDCA, you don't have a unified approach to quality. And I think some things fall out. The first thing is we need to revise this. I think it's much more complex. We are making critical improvement decisions based upon data that we don't know the validity of it, because it's not a common step to check the validity of the quality data that we've gathered. And the second is we have never studied on a routine basis the impact. You have only a certain number of resources you can dedicate to quality improvement. And unless you know, are you achieving the impact that you intended when you started that improvement? Say the impact was to reduce waiting times in ambulatory care. And yes, you reduce that, but you've increased costs because you've hired other registration people. Or is it to improve satisfaction? Or is it to reduce costs? Unless you study that before and after, you will not know if you truly achieved that cost and it was worth the value, it was worth the input of resources. You have to get very astute at that. This needs to be a part of every improvement cycle, is defining the impact and being able to gather some metrics to know whether we reached it. And finally, integrated oversight. We've about reached our limit of the time here. We started a little bit late, and if you will please give me the high sign when we're absolutely out of time. Let me tell you a story with this. I was invited by a hospital to go to lunch with their senior staff. I said, sure, love to. So the CEO said, I'd like to introduce my team to you. This is our quality leader. This is our vice president for patient safety. This is our director of facility quality. And went around the table, and all these people were on the quality patient safety team of this hospital. And I said, that's fantastic. How frequently do you all meet? You know, we try to meet once a quarter. Oh, the CEO meets with you? Well, it's really hard. He's got a tight schedule. Well, at least you go to meetings together. Oh, we all go to different conferences. Well, where do you publish? In different journals. Do you budget as one group? Oh no, we each have our own budget. So what you're seeing, we are trying to break down silos within the departments of a hospital. But many hospitals, in their rush to staff up and ramp up for patient safety and quality, are starting to create silos within patient safety and quality. We need to go back and look, is this truly an integrated effort? Is it budgeted from one global budget within the organization? And the fourth is they need to bring quality data into management. And only leaders can do this. There is some publications out on evidence-based management. But in general, the people who understand quality improvement, the importance of data, have been on the clinical side. They have not made a conscious effort to translate the knowledge, to transfer the knowledge and the expertise and the excitement about using data onto the management side of an organization. Now, let me give you a couple of examples here that may illustrate that. The first one, your hospital needs to purchase additional infusion pumps. Finance normally sends out an RFP and takes the lowest bidder. Their fiduciary responsibility. But your hospital already has 3 different types of infusion pumps. And the lowest bid comes back from a 4th company. So you say, well, what kind of data do we have to inform this decision? Number one, if the quality people and the nurses in particular are not sitting in the room when this decision is made, it won't be the correct decision. I can assure you. Now you're going to have so much data that you could bring to this meeting to inform the decision. The one that is on this list here that's most important is, what is the cost of training all of your staff on a new piece of equipment? I can assure you it will usually be more than the difference between the best infusion pump and the cheapest infusion pump. So you have to look at all that. If you bring to your nursing staff, here we have a 4th pump with a different alarm system. We know that have implications for patient safety, different on and off switches. That is going to create patient safety issues. So the real thing here to know is that this is financial due diligence plus quality and patient safety due diligence. Second situation, your department discovers that there's a shipment of antibiotics that just don't look right. And then it's about the same time your biomedical equipment department thinks that they've gotten some fake pacemakers. What kind of data do you bring to this to decide what to do? Well, there's national data, there's information from manufacturers, there's certification processes for suppliers. So there's a lot of information that you could bring here to understand the safety of the supply chain. And supply chain management is an enormous patient safety issue across the world. It's a component of patient safety that has been ignored, but it is an issue. Counterfeit and bandages, drugs, devices are flooding the world, and it has to be considered a patient safety issue, and supply chain management is critical as we go forward. We're a global society, so it's the risk of substitution, it's the risk for diversion, portion of all of the shipment, it's degradation of a product. Now, we know that frequently drugs, pharmaceuticals get held up in customs. Well, there are now small chips that can go into the drug boxes that will then record if it's been kept, what the temperature has been, so you could understand whether it was potentially degradable or not. We met for a couple of years with Medtronic, Johnson & Johnson, who report that there's fake non-sterile bandages all over the world, flooding the world. And we have to consider that this is a reality that we have to live with, and it's particular acute for the pharmacy. I'm going to just, for the sake of time, skip some of these statistics from WHO, but it tells you it's in Russia, it's Peru, it's everywhere. And this is just an example of the supply chain, if you want to do that. Let me get to the very last systems thinking here. We've heard repeatedly that we need to think that it's not individuals, it's most likely processes, but processes, many processes make up systems, and systems interact with each other. Unless we bring our understanding of quality and patient safety up to the systems level, we will have difficulty accommodating the high risks that are coming to us in the future. We looked at this as communication is one critical system. And in all we do, we communicate not just with patients, but we communicate all day long unless we know that it's correct, secure, confidential information and how we manage it, we will have difficulty. And especially the overlap with management systems. When you look at systems and you're trying to fix a system, think about what tools are good to evaluate a system and improve a system. Proactive risk assessment you can use across the whole system. Here's an example of just looking at high alert medications, but it gives the kind of approach that we need when we look at systems. If you list the most critical high alert medications, they certainly are the ones that will impact the patient outcome the most. And you want to design strategies then that reduce risks in the system, not just in one process in the system. Look-alike, sound-alike medications are really an issue that is ripe for this kind of risk-based approach. They look alike, they sound alike, there's multiple concentrations. You can see here these medications very different. They look alike, the names on the left. First you need to understand from your quality data what are the most problematic ones, and start there in terms of your risk reduction. Here's just something I thought was rather clever and I kept in. It's called the tall man characters, so that if you look at the medication on the left and how it's spelled on the right, or even putting part of it in red or capital letters, you can begin to very visually and quickly differentiate drugs that potentially get mixed up. Now, you can look at this as a clever little thing coming from the pharmacy, or you can look at it as a system. When you look at it as a system, then you think about, well, we have to change our order entry system. Well, we have to change this. We have to. So you think about how this changes the entire communication of drug names and information to reduce the risks. So the last thing is, do a system review at least once a year. This is not just producing a report from the pharmacy on the number of near misses or drugs that were added to the formulary. This is everything. And it should be a learning tool. It's not a report to just send to governance that gets filed as an appendix to the minutes. This should be a learning document. For example, if you have added a particular drug to your formulary, make sure that it is being used for the intended purpose. If that drug requires monitoring of liver function tests or so, make sure that is being done. So there's different levels that you can gather information, cultural information, and so to understand whether you really have a report you can learn from. Thank you.
Thank you, Dr. Paul, for that very comprehensive and excellent presentation. He covered everything from systems and processes to accountability and culture to how we can improve those processes, and he shared with us many case studies as to how errors happen and what needs to be improved. And believe you me, these case studies do not happen only to third parties and to people, they can happen to anybody of us. I was at a FICCI conference on 1st and 2nd September, and in the healthcare IT section, a very senior lady from the healthcare sector and allied healthcare field got up, and she was almost moved to tears as she narrated how she lost her mother because she was prescribed Telma, an antihypertensive drug for blood pressure less than 100 milligram of mercury rather than more than 100 milligram of mercury. Just that one small mistake in the discharge summary of the less than or more than sign took away the life of her mother. Thank you, sir, for that presentation. We open the house to any questions if you have. Thank you, sir. That was very comprehensive.
Thank you very much. I would now just ask Dr. Shweta Dewan to kindly hand over a memento to Mr. Jagdeep Singh, please. And ask Mr. Jagdeep Singh to kindly hand over a memento to Dr. Ostenberg. Thank you very much. With just a few things to be done before the conference is wrapped up is the announcement of the award winners for the poster sessions, but we will have to wait for the other session to get over, the infection control session that is going on at Pala Hall. Till that time, you can stretch your legs or kind of interact with people. The question, okay, and the questions that you need to ask to different speakers all through the day, you can feel free to come ahead, come up here and ask them, till we wait for the people to come down from the Pala Hall for the infection control. And certificates are available at the back. If you have not yet collected your certificates, please wait and collect the certificates from the back, from the organizers. And it's just not the poster prize announcements. You have to be physically present in this hall. If you feel that you have any chance to win that iPhone 5S or the Samsung Galaxy 5, so you need to be present here to collect it physically. Okay, like all good things, this also will have to come to an end. And before it comes to an end, we'll have the announcement of the poster awards. And I would request Dr. Rupali Basu, the CEO of Apollo Clinical Hospitals, as well as the CEO of the Eastern Zone of the Apollo Hospitals Group, to please come up stage. And as we announce the winners, she can kindly hand over the prizes. The prizes are ready? Yeah. So the best poster, and the best poster is entitled, "Is there a need for dedicated training hours on pharmacovigilance in nursing curriculum in India?" And this poster was presented by the Peerless Hospital and BK Rai Research Center. Is there anybody? Okay, please come over and take your prize from Madam. So could we have a round of applause for the poster from Peerless Hospital and BK Rai Research Center? Please come up. The poster was titled "Development of an innovative, customized and integrated hospital." Is there a need of dedicated training hours on pharmacovigilance in nursing curriculum in India? That's Peerless Hospital and BK Rai Research Center. Thank you. The next prize is for the best e-poster. And the best e-poster was called "The Development of an Innovative, Customized and Integrated Hospital Fire Safety Plan." And this came from the Mission Hospital, Durgapur. So any representative from the Mission Hospital, Durgapur? So if there are no, we'll ensure that the prize reaches Mission Hospital, Durgapur. Okay, a big round of applause for Mission Hospital, Durgapur for the best e-poster. Development of an innovative, customized and integrated hospital fire safety alarm. And the last award was the best poster, which was the Delegates' Choice Award. That's the delegates had voted for this. And it went to Shubharti Medical College, Lucknow, for pathogenic bacteria in the hands of an hospital staff. Shubharti Medical College, Lucknow. Nobody from Shubharti Medical College, Lucknow? Okay, Shujoy will have to spend a lot of money to send it to Lucknow now. Okay. You do the honors of taking it and sending it as well. And please put a hand together for Dr. Shujoy Kaur. Put it all together. One blood. Okay. And now this is something that I think everybody is waiting for. And that is the lucky dip. Shujoy? Rana? So the what's online is iPhone 5s and a Samsung Galaxy S5. Shake it well and then pick up that winner. The person has
Okay,
to
if
be
you're not
physical.
there, yeah, if you're not there, you won't get it.
Yeah, yes, you have to be physically present. Over here, it was clearly announced. Can you announce the name again, Shujoy?
Lizu Thomas from Chennai.
Lizu Thomas from Chennai.
Okay, we'll give it
is
to anybody
going
from
3,
Chennai.
2, 1, gone.
The next one.
Oh, this one doesn't have a name.
The man or the lady with the name. See, we are third time lucky, Shujoy.
Suchandra Ghosh.
Suchandra Ghosh.
Suchandra Ghosh, Kolkata.
Suchandra Ghosh, Kolkata.
Suchandra
Anybody?
Ghosh. No, you have to be Suchandra Ghosh.
And you have to have a proof of identity to prove that you are Suchandra Ghosh.
Not there.
Gone 5, 4, 3, 2, 1, gone. Next. Can you announce that name again, Shujoy?
Dr. S.L. Khandalkar.
Dr. Khandalkar.
Khandalkar.
He ended up that session with that fiery remarks and he goes home with a smartphone. The smart doctor goes home with a smartphone.
I don't think I have words to say. A big, huge thank you to everyone, all of you who have come from all the 36 wonderful countries to us. A big round of applause for all the speakers. All of your knowledge, all of your learning, all of your sharing will be with us for the whole year. And for the rest of our lives, we will work on them. That's our promise to all of you. And I think a big thank you to each one of you delegates all of you who have really chosen that THIT as well as IPSC are the two important events for all of you. You have understood the value and you have been here. So thank you very much to think that patient safety and transforming healthcare with IT is important. We think it is important. All of you have thought so with us. So thank you very much. Also a big thank you to all our sponsors. Half of our cost is covered by them. It's not the full cost, but big thank you to all of them. Big thank you to the sponsors. Some of them are here, represented here. And I think the last but not the least, the huge team that has, part of it is here, but actually a huge team back there in the hospital about 4 kilometers away, and the entire Apollo Hospitals group and everyone, all of you who have really worked hard for this conference. A big thank you from me personally to all of you, and think for all of us to all of you. So thank you very much. Thank you very much. Thank you. See you in Bangalore. And see you, all of you in Bangalore, because that is the next venue, next time, next 6th and 7th? 16th and 17th. 16th and 17th of September. October. I'm sorry. 16th and 17th of October 2015 in Bangalore, India. All of you are cordially, personally, warmly invited to be there. Thank you all very much again. Thank you all. Thank you so much.
Hello.
Can you hear all of us? Can you hear? Now I just want an attention from all of you. Please, wherever you are, please put your hands together and make a big round of applause for Dr. Sujoy Kaur. No. But Sujoy, you have to also say few words for all of us. You can't just get away with not saying.
Yatish, your time has started. And you can't conspire anymore. Okay, this has been really a good journey, and it's come to a moment